For the undergraduates out there who are listening in or watching this session, general physical examination is what you really need to know in and out, because that is what will save you in your exams. In your final year MBBS medicine practical exams, you will be judged not based so much on systemic examination. Systemic examination, you can afford to make mistakes, because when I say make mistakes in terms of interpretation. So how to elicit a particular sign, if you're asked to demonstrate, for example, in neurology, if you're asked to demonstrate how to elicit the knee reflex or the ankle reflex or the Babinski sign, you need to know how to demonstrate. Now, once you have elicited, to interpret it, was this deep tendon reflex brisk? Was it diminished? Or was it normal? So that you can be sort of forgiven, because interpretation comes only with experience, whereas eliciting comes with practice. So if you have practiced enough, you should execute that demonstration part smoothly. Even if you're not able to interpret what was the actual finding, you struck using your knee hammer, you elicited the reflex, but then to interpret it, was it exaggerated? Was it diminished? You were not able to, or you got it wrong. It was actually diminished, but you, by mistake, you said it's normal, or by mistake, you said it's exaggerated. You'll be forgiven, because you've not seen enough for you to be able to confidently interpret. But to confidently elicit is not difficult. So that's why you should be focusing on demonstrations, no doubt. But in general physical examination, no mistakes allowed. You should know in and out everything, because general physical examination, you should have seen enough patients. You should have attended your wards, your clinics, your practical classes, and perhaps beyond that also. Maybe in the evening times, you should pester your postgraduates in your college, in your medical college, to take classes for you guys. So it's beneficial for both parties. When they take classes for you, they also improve, and so do you. So you should go back in the evenings. Maybe uh, sometimes there's a little bit of barrier between a faculty and an undergraduate student. That barrier is less between undergraduate and postgraduate medicine students. So that's why you should take advantage of that and try and go spend extra time in the wards and ask an interested postgraduate to take classes for you. So with that being said, general physical examination, you all know, is part of examination. It's the initial aspect of examination. Um, does anybody have a doubt? Preetham, did you raise your hand? Or was it by mistake? If there are any questions, you can always ask at any time. I presume it might have been a mistake. I'll continue. So initially, we start out with general physical examination. At the end of history, you have a provisional diagnosis in mind. You're thinking it might be diagnosis A, B, C, and therefore your examination will be directed by what your initial differential diagnosis at the end of your history. What was your provisional diagnosis? That will help you to decide what are the aspects you want to focus on when you're examining. So general physical examination initially, and then the systemic examination. Which system do you focus on? That will be guided by what your provisional diagnosis at the end of history was. So in general physical examination, getting straight on with it, please remember vitals should be mentioned first. So make it a habit. Uh, they're called vitals for a reason, vital parameters, because that helps you to decide what is the status of the patient. How detailed can I go? If I'm seeing a particular patient for the first time, I need to know how the person's status is. Can I take my time? Can I do a detailed examination, or do I need to be fast? Do I need to be focused only on certain aspects and immediately start management if necessary? So that is why if the person has unstable vital parameters, then I cannot afford to do a very detailed examination. I need to relieve them of their discomfort, of their current problem, so that once they're comfortable, I can then perform a more detailed examination. So vital parameters always need to be mentioned first, so that it clears the air out. This is what the status of the patient is. He's stable enough, he or she is stable enough for us to proceed for a detailed examination. Or by chance, if you're in the emergency room and you've come across a patient who has a blood pressure of, let's say, systolic 80, then you can't really be doing very, very detailed examination. You need to save the person's life first. So you need to address that hypotension. And then once the person has stabilized, maybe later you can do a more detailed examination. Okay, so vitals first, supportive devices. Now, very important, and it gives a very good impression. So all the time in the wards, there are patients for whom our students take history and examine, and then we discuss the case sheet during the classes. But a lot of times, what is missed is this. So, supposing a person has an IV cannula, which most patients who are admitted to wards will have an IV cannula, or let's say they have something else. It's a stroke patient who's unable to swallow, who has dysphagia, so he'll have a nasogastric tube. Or perhaps it's a bedridden patient who has deep vein thrombosis stockings, DVT stockings, compression stockings, or has an indwelling catheter, urinary catheter. So you need to mention them. Or perhaps it's a COPD patient who has nasal prongs, oxygen delivery device, nasal prongs are there. You need to make a mention of anything additional. So it's not just the general physical examination restricted to the patient's body, but also any additional devices that you can notice on examination. Please do mention it. It makes a good impression. So it tells the examiner that you've been thorough in noticing these things. So it's all about how keen your observation skills are in general physical examination. How thorough have you been in trying to find out what is normal, what is abnormal, what are the manifestations, what are the features that you can try and detect. So please make a mention of the supportive devices, whether it's oxygen and so on. So that also I'll just make a mention, but you please keep it in mind and not to forget it when you are describing physical examination findings, and then head to examination. Okay. So a lot of times GP, when it comes to GP, what students end up saying inadvertently or out of naivety is pickle. So GPE is equal to pickle for a lot of people. So am I right? Do you guys agree? Uh, do you have that habit of saying pickle when you are describing general physical examination findings? So the basis of pickle was how do you bring up the level of discussion such that you should make sure you're covering most major points in general physical examination. So one of the ways was to try and fit these six most common findings, general physical examination findings, into an acronym like this, just to make sure that students or the learners don't miss out on at least these few findings on general physical examination. But these are very, very important, no doubt. These are not the only things that you should be focusing on. You should also have your examination findings, your general physical examination clues that you're trying to search for should be relevant to your case. So, for example, if it's a patient who has acute gastroenteritis, so pickle, you all, I'm sure you all know, your seniors would have taught you, and you yourselves would have discussed amongst yourselves. So, pallor, and then icterus, and then cyanosis, clubbing, lymphadenopathy, and edema. So if let's say this is pickle. Now, if I'm taking the history and I'm examining a patient who has acute diarrhea, so acute gastroenteritis. Now, in a patient with acute gastroenteritis, if I just say look for this pickle and leave it at that, it will not be appropriate. I'm sure you'll agree. Because why will an acute gastroenteritis patient have edema? It's the opposite of what I expect. So I'm looking for dehydration. So what I should be looking at should be features or evidence of dehydration on examination. So it's important to have that presence of mind to keep your mind on what the diagnosis or what the problems of the patients are, and then focus your examination based on that. Likewise, let's say a patient has uh, it's a bedridden patient. It's a stroke patient, maybe a paraparesis patient, a spinal cord injury paraparesis patient. So in that case, I should be looking for additional features apart from pickle, just pickle. Should be looking for other features of what complications bedridden patients can have. Like for example, deep vein thrombosis, so DVT. So you should try and ideally you should make it tailor-made. So it should be suited to what your suspicion in that particular patient is. So try and keep that presence of mind. And the better you get at it, the better your overall development as a clinician will be. Okay, so if there are postgraduates among you who have joined here for the session, so this is what something you should try and inculcate into your everyday assessment of patients. So make sure when you're writing case sheets, keep writing case sheets. It's always good practice. The more case sheets you write, the better you get at it. The easier it will be during your exams. So during your exams, the way you want to present, that should be practiced right from the first day of your post graduation, where you're writing case sheets. It becomes second nature. So then you don't have trouble during exams. Okay, so as I said, vital parameters first. You all know that vital parameters, there are four main things that we look at: blood pressure, pulse, respiration, and temperature. Nowadays, there's this habit, especially post-COVID, there's this habit of mentioning oxygen saturation based on the finger probe. Most old-time examiners will not really accept this as a clinical parameter that you're measuring. You're using a device. No doubt for blood pressure also, measurement also, you're using a device. But this is acceptable. In fact, this is vital. It's very important. This is also important, but not always considered classically considered as a clinical finding. It's more like an investigation finding, especially when you're using devices which are not always well validated. So not produced, not made in India, made in some certain neighboring countries. So when that happens to be the case, you're not always sure about whether the reading shown on that probe is correct or not. So that's why examiners may not accept if you say this is the saturation as part of the vitals. It's always better to skip that part. Instead, just stick to the classical four vital parameters, that is blood pressure, respiration. So your respiratory rate will give you an idea of whether the person's saturation might be low or not. And further on, when you're examining, you will get an idea if the patient is cyanotic or not, and then if the accessory muscles of respiration are in action or not. So those will guide you, or respiratory rate is high or low. Sometimes bradypnea, especially if let's say a patient who has overdosed on opioid drugs. So if a patient has consumed opioids or overdosed on opioids, they'll have bradypnea and they'll have cyanosis. So their saturation levels will also be low. So bradypnea could also indicate a respiratory issue. Whereas tachypnea would also add to the same. So that is a better indicator of respiratory problems rather than the probe measured oxygen saturation. Okay, so starting out with vitals, and in that blood pressure, very important. Blood pressure, how are you expected to measure? So you should know the basic things about how to measure blood pressure. You should know that you should, you should know that the level of the sphygmomanometer and the arm to which the BP cuff is applied. So if you have applied it to the right arm or left arm, the level of the cuff where it's placed, the level of the sphygmomanometer and the heart, all should be at the same level. Okay, so if the person is seated, they should have their back supported. They should have been at rest for at least 15 minutes. So this is the ideal way to measure blood pressure. Obviously, it may not be possible during your exams. But in a clinic, when you're measuring blood pressure, the person supposed to have been seated, relaxed for at least 15 minutes. They shouldn't have smoked in the past 30 minutes at least. And they should have a back support when they're seated. And then when the blood pressure measurement is done, the sphygmomanometer is kept at the same level as the heart and the BP cuff. Okay, all three at the same level. That is the ideal way. Or let's say in your exams, the person is supine, patient has hemiparesis. Then in that case, you can always keep it on the bed. That brings the cuff, the sphygmomanometer, and the heart at the same level. With the patient supine, you can measure the blood pressure. Okay, so one very, very important point you should keep in mind is if the person is having hemiparesis, do not measure it on the weaker side. So the blood pressure. So don't measure blood pressure. Don't measure blood pressure on the paralyzed arm. So important to avoid that. But that's because the hemiparesis may also involve dysfunction of autonomic dysfunction, autonomic system, nervous system dysfunction. So that's why the blood pressure may not be representative. It may be falsely low also. So that's why, a patient with hemiparesis, let's say a person has a left-sided hemiplegia or hemiparesis, then you don't measure the blood pressure in the left arm, measure it in the right arm. Okay, keep that in mind. One more important point to keep in mind is, if let's say the patient has atrial fibrillation. So atrial fibrillation patients, you cannot just take one blood pressure measurement value of systolic and diastolic and give out saying that these are the blood pressure values. The systolic is this much, diastolic is this much. No, because in atrial fibrillation, the rhythm is irregular. So that's why each stroke volume, each cardiac cycle's stroke volume will be different. So that's why one single value will not be representative. You should take an average of 3 systolic blood pressures divided by 3 diastolic blood pressures. So this will give you the average blood pressure. This is what you have to mention. So average systolic BP divided by average diastolic BP. So for example, the first time I measured in a patient with atrial fibrillation, I got 120 by 80. Next time I measured, I got 110 by 70. Another time I got 100 by 60. This is, I maybe it's just an example, okay, little bit of exaggeration. But if I got these kind of 3 values, so what I should do is I take an average of the systolic, that comes out to 110, divided by the average of the diastolic, which comes out to be 70. So finally, I'll say the average of 3 systolic and diastolic recordings were 110 by 70 mmHg for a patient with irregular rhythm, because each cardiac cycle, the stroke volume will vary significantly at times. Okay, so keep these 2 points in mind. If a patient is having atrial fibrillation, measure 3 times and take average of systolic, divide by average of diastolic. If it's a hemiparesis patient, don't measure it in the paralyzed side, measure it in the opposite side. Otherwise, measuring it in itself, the cuff has to be tied, the tubing has to be medial. Okay, the brachial artery is, you're measuring in the arm. If you're measuring blood pressure, you're measuring it in the brachial artery. So the tubing on the cuff, that tubing should come medially, and it should lie just above the brachial artery. And how do you locate the brachial artery? It's just medial to the tendon of the biceps. So if you can locate the brachial artery, and when you're placing your the chest piece of your stethoscope should be just underneath the cuff. Okay, so the cuff is here, the tubing is here in the medial side, and your chest piece should try and sneak, or rather tucked in. It should be tucked into the underneath the cuff. Okay, so ideally you should be trying to place your stethoscope in the middle of the cuff, but you can't go all the way there. You should be able to pass just a little finger between the skin of the arm and the cuff. So that will not allow the entire chest piece to be able to go till the middle of the cuff. So that's why you need to go in a little bit as far as you can conveniently go, and place it there when you're using the auscultatory method. Okay, when you're auscultating using the auscultatory method, that is how you're supposed to use. But before the auscultatory method, always go for palpatory. So if you're asked, for example, by chance your examiner asks you, please demonstrate how you check for the blood pressure. So make sure all the 3 are in line, the same plane, and then make sure these 2 are checked off. You're not measuring it in the paralyzed side, and if the patient has irregular rhythm, you're taking averages. First, go for palpatory method. You'll get an estimate of what the systolic blood pressure is. Based on that, you will apply the auscultatory method. Auscultatory method, everybody knows about the Korotkov sounds, auscultatory. And based on the at what pressure did the Korotkov phase 1 sounds start, divided by at what phase did or at what pressure did the Korotkov phase 5 happen. That means the disappearance of those sounds. So basically, the principle is you're obliterating the artery first, and then you're seeing at what pressure does it initially open up. That gives you the systolic blood pressure. Versus at what pressure does it fully open up. When it fully opens up, there's no turbulence. You'll not hear the Korotkov sounds anymore. Basically, it's all because of turbulence. So when it is totally closed also, you'll not hear any Korotkov sounds. As you release the pressure, slowly it opens. That time blood starts flowing initially. That is your systolic blood pressure. And finally, when it is fully open, blood is now smoothly flowing. So you'll not be able to hear any Korotkov sounds. That is phase 5. So 1 by 5 gives you systolic by diastolic. So always go for the palpatory first, then the auscultatory. This is to avoid missing something called auscultatory gap. Okay, so there's something called auscultatory gap. If you directly go for auscultation, you might miss the initial 10 to sometimes even more millimeters of mercury systolic blood pressures. There may be a gap. So initially, when it just opens up, that time the auscultatory that Korotkov sounds start. But then as you release the pressure more and the artery continues to open up, that time briefly the sounds may disappear and then again reappear. So that gap should not be missed, and that is why doing the palpatory is always better to get an estimate of what is the systolic. Based on that, your auscultatory, when you're raising the pressure, the difference should be 30 millimeters of mercury. By that I mean, for example, when you were trying to check for the palpatory method, remember palpatory gives you only systolic blood pressure. It does not give you diastolic value. So when you are using the palpatory method, you inflated the cuff and the pressures in the cuff went up, and then you're slowly releasing it. You were palpating the radial artery all along. And as you stopped feeling the radial artery pulsations, then you raise the blood pressure till then, and then you start releasing the pressure. So as the pressure is coming down, first, at what pressure did you start feeling the radial pulse again? That is the systolic blood pressure on palpatory method. So suppose you got it at 120 mmHg. At 120 mmHg, you started feeling the pulse again, the radial pulse again. So when you're re-inflating, again you have to re-inflate. But this time you'll wear the stent and keep the chest piece underneath the cuff. When you're re-inflating, you need to re-inflate to at least 150 mmHg. So let there be at least a 30 mmHg gap between your palpatory and your auscultatory cuff pressures. Okay, this is in order to not miss the auscultatory gap. Clear? Auscultatory gap is very common among hypertensive patients. That is why you should not directly go for auscultation. Please don't treat blood pressure measurement as uh, as like a burden or as an extra work. It's part of your being a clinician. Okay, especially like for example, anybody who in future practices as a clinician, do not hesitate. Even if you're not in medicine, if you're not a medicine person, also you should continue measuring blood pressures. Okay, very important. Okay, Fatima is asking palpatory systolic BP equal to auscultatory phase one sounds. No, not necessary. That is what. So, oh, you mean the before the auscultatory gap, you mean? No, that's what it need not be. So auscultatory will generally be slightly there'll be a variation. So generally the auscultatory is little more sensitive. You'll be able to hear it little earlier than the palpatory part. So that's why the auscultatory finding will be the level at which the auscultatory findings start will be slightly higher than the palpatory. So that is why you need to elevate it to at least 30 mmHg more than what value you got on uh, palpatory. Okay, so the ear is a little more sensitive, so you'll hear it a little earlier than you start feeling it with your fingers. So that's why elevate it a little higher, preferably 30 mmHg. And when you're bringing it down, no, when you're releasing the pressure, release it by 2 mmHg per second. This is what is recommended. 2 mmHg per second is, you can't lower it too fast also. That's a mistake that a lot of us, especially initially, we do. So when you're releasing the pressure, you release it so fast. Then you miss it. Exactly when did the phase one start, or when did the phase five happen, or when did the sounds disappear? So reduce it slowly. 2 mmHg per second is what is lowering it at 2 mmHg per second is what is recommended. Okay. Yeah. So otherwise, make sure that the patient is not has not just let's say walked or stressed out and then come and sat and you immediately check their blood pressure. No, you need to allow them some time to at least relax before you measure it. Ideally 15 minutes. I know it's not possible in any clinic or any OPD to give 15 minutes to each patient to relax before measuring their blood pressures. But that is what in an ideal world is recommended. Okay. Beyond that, for your exams, these 2 points are important because you may have these cases. So keeping these in mind are important. Okay. Otherwise, hypertension based questions may be asked to you. So what are the problems related to hypertension? You know that hypertension has a lot of cardiovascular adverse effects, including it's related to adverse events, including atherosclerosis, including coronary artery disease, heart failure, including renal dysfunction, including strokes, subarachnoid hemorrhages, and so on. So, and eye changes also. So Keith Wagner staging of retinopathy, hypertensive retinopathy. So a number of adverse events or adverse complications are associated with hypertension. You may be asked questions based on that. So you have to keep that in mind. Okay, and then hypotension also, shock. So we talked about systolic and diastolic. What is mean arterial pressure? Mean arterial pressure is, there are two formulae. You can use either of them. So twice diastolic blood pressure plus either 1/3 of pulse pressure or uh, systolic blood pressure whole divided by 3. So there are two formulae. That is diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is what? Pulse pressure is difference between systolic and diastolic. That is your pulse pressure. Pulse pressure is systolic minus diastolic. Very important because volume of pulse, when you check for volume of pulse, it is only indicating the pulse pressure. Okay. So difference between systolic minus diastolic is pulse pressure. Mean arterial pressure is rough. These two, both these formulae are correct. You can use either of them. Okay. Why it's important is if it's less than 65, then we deem it to be shock. If the mean arterial pressure is less than 65, then it indicates that the person is in shock. One thing you should keep in mind is shock is not equivalent to hypotension. Person may have hypotension and not be in shock. Likewise, patient may be in shock, yet the blood pressure is normal. Okay, so they're not equivalent. Shock means reduced perfusion to the tissues. Yes, blood pressure is a very important parameter in deciding whether the tissue is getting perfused adequately or not. But it's not, they're not, you cannot equate the two. Okay, so that's why, especially thin, young girls in their in their 20s, they may still have a blood pressure that seems to be very low, but their organ functions are absolutely normal. That's because that much pressure is enough for their organs to function. So you can't deem a hypotensive patient to necessarily be in shock yet. They may be going into shock also, but it's not equivalent. Likewise, just blood pressure is normal. So if you're wondering whether a person is who has hypotension, who has low mean arterial pressure or low blood pressures, if they are having shock or not, look at their organ functions. So which organs do we look at? We generally look at the skin. Are the peripheries cold and clammy? Are they getting perfused or not? We look at renal functions. That means, are they producing enough urine output? Kidneys are a very, very good indicator of um, uh, whether the person is in shock or not. If the kidneys are receiving adequate perfusion, if the kidneys are getting perfused well, they'll produce enough urine. So if they're passing urine well, it's a very good indicator that they're likely not in shock, at least yet. Okay, because shock should be expected to produce pre-renal acute kidney injury. So in that case, the urine output should come down. But if the perfusion is adequate, then the urine output would be maintained. Okay, likewise, neurological. So CNS, look at whether the person is disoriented, whether the person is confused. So if their blood pressure is maintained well to the brain, their orientation will be normal, their functioning of the cortex, that means the high mental functions will be normal. So you can always judge whether the person is in shock or not based on organ function. That's more important. Okay, so that's about blood pressure. Always check the blood pressure for any patient. Gives you an idea of how critical the patient is, or whether you have time to do a detailed examination or not. Okay. So the next parameter is, of course, pulse. So a very common mistake that students make is while describing pulse, they'll just say 65 per minute and done. They'll move on. No, it's not just about rate. So yes, rate is important, but rate, apart from that, rhythm, anything else? Can you guys tell me what else do you look at when you are examining pulse? What are the subheadings under which you should describe pulse, and you are expected to describe pulse? Volume, excellent, Shantish. I'm sorry. Volume. Volume of pulse. Character, excellent. Character. Rate, rhythm, volume, character. Excellent, Kushali. Excellent, Yash. Very true. Ashini says condition of the vessel wall. Excellent. Radio-radial delay. You guys know it all already. Very good. I'm glad you guys already know all of this. Radiofemoral delay. Okay, then I'll put it as delay. Very good. Very good answers. Yash, Kushali, Saima. Excellent answers. Yes. So make sure you don't make that mistake of describing pulse as only this much rate per minute, this much beats per minute. So this is what I'm talking about. General physical examination, no mistakes. Don't allow the examiner to catch you at this stage, at the stage of general physical examination. So you should be thorough. If you're Shaker says comparison of the two sides. Absolutely. So comparing the volume of pulse, peripheral pulse on both sides. Absolutely correct. So make sure your description of general physical examination findings and your approach to how to examine the general physical examination findings is absolutely correct. Okay. After that, once you go to systemic examination, you're actually doing well. So all you need to do is get the format of the systemic examination correct. And if you're asked to demonstrate something, demonstrate it correctly. Don't make mistakes in demonstration. For example, if you're asked to demonstrate plantar reflex, don't stroke the medial aspect of the sole. You have to stroke the lateral aspect. So if you stroke the medial aspect, then what the examiner will think, either you've not gone to the wards, you've not attended classes, or you've been taught wrong. So obviously taught wrong, nobody will really think that can happen. So they'll presume that you've not gone to the wards, you've not attended classes, then it's a little bit of a problem. So absolutely right. So, rate, you guys know what is the normal rate, 60 to 100. If the pulse rate is less than 60, it's called as bradycardia. So you should know some causes of bradycardia. Okay, you may be asked, name 5 causes of bradycardia in your exam. So you should already have your answer organized. So what are the physiological causes? What are the pathological causes? So physiological causes of bradycardia, for example, sleep. Any other physiological cause for bradycardia? Athletes, excellent, Yash. So athletes have a higher vagal tone, resting vagal tone, and that is why they have bradycardia, which is not pathological. That's physiological. Then there are pathological causes. Always keep in mind drugs. So certain drugs which may cause bradycardia, including verapamil, diltiazem, beta blockers, excellent, Yash, digoxin for that matter. All these can cause bradycardia. Then there are a number of other causes. So if we had to talk about, let's say, brady, apart from the physiological causes, let's zoom it in. So physiological, we discussed about sleep and athletes. So remember, if the resting heart rate is high, if there is resting tachycardia, that goes very much in favor of some pathology. One of the most prominent causes being hyperthyroidism or thyrotoxicosis. So physiological causes. Then pathological causes, drugs, absolutely correct. Apart from that, you should also think of sometimes toxins, especially unfortunately OP. OP compounds, because of their procholinergic, they are acetylcholinesterase inhibitors. So they'll increase the cholinergic effects. So bradycardia may end up happening. That's why one of your targets, when you're treating patients with OP, you have atropinization targets. So one of the targets is to try and keep the pulse rate high, above 80. Okay. Other than that, sometimes you can have it as a result of hypothyroidism, endocrine causes. So hypothyroidism, useful because you can reverse this to discuss causes of tachycardia. Correct? So hypothyroidism causes brady, hyperthyroidism causes tachycardia. Beta blockers cause brady, beta 2 agonists or beta agonists cause tachycardia. But there are certain other causes also. Ischemia. So Cushing's reflex. Excellent, excellent answer. Very good. What is Cushing's reflex? Where do you see it? Cushing's reflex happens in raised ICT. Excellent. Neurosurgery. Sumaya. Absolutely right. So raised ICT. Raised ICP can lead to bradycardia. Inferior wall MI. Excellent answer. Yes, I was about to come to that also. Inferior wall MI. Hypothermia. Excellent. Excellent answer. Hypothermia. Very good. Inferior wall MI definitely causes bradycardia. Very high chance of causing AV nodal blocks and therefore bradycardia. You should also keep in mind there can be AV blocks, AV nodal blocks. So basically, inferior wall MI also produces AV nodal block. Generally, it will be transient. Transient AV nodal block happens in inferior wall MI. Sumaya says hypertension, bradycardia, hypothermia. Yeah. Hypothermia, bradycardia, correct. Hypertension. Are you referring to Cushing's reflex? Cushing's triad? Okay. Cushing's triad, very good. Hypothermia is not the third part in Cushing's triad. Cushing's triad, the third part is Biot's breathing. Okay, so it's basically affecting the vitals in Cushing's triad. So BP, pulse, respiration. So BP will be high, pulse rate will be low, and respiration will be irregular. That is called Biot's breathing, irregular. Biot's breathing. Biot's. So when you talk about respiratory patterns, mainly abnormal patterns, we have three main patterns. That is Cheyne-Stokes breathing. We have Kussmaul's breathing, and then Biot's breathing. Biot's breathing is actually just irregular, no rhythm, no predictability. That is something that is seen in raised ICP. That is a third component of Cushing's reflex. Cushing's triad. Cushing's reflex is just bradycardia. Very good. Good, great answers. Okay, sometimes bradycardia can also be seen in direct hyperbilirubinemia. So very high direct bilirubin levels, bilirubin, that can also produce bradycardia. Okay, and then any cause for AV nodal block. AV nodal block itself, that may be asked as a 5-mark question for you guys in theory, for undergraduates, I'm saying. So what are the causes of AV nodal blocks? So apart from all these, so you can have drugs also causing AV nodal blocks. You can have inferior wall MI. Just aging itself, age related. So that itself can cause. That's something called Lev's disease. Okay, fibrosis, Lev's disease, fibrosis of the AV nodal. Apart from that, even electrolyte abnormalities, calcium elevation, potassium elevation, hyperkalemia can have a lot of impact on conduction. So these can also lead to bradycardia. So a number of these causes are there. So you should know at least like 5 in case they ask you like that. The examiner asks you name 5 causes. So what generally happens, when the examiner is conducting your viva, they see how they allow you to present, and they ask you a few questions and see how far you can take it. So maybe you get stuck at a certain place. Maybe while presenting, while you're he's asked you, the examiner asked you present the systemic examination finding. You got stuck there. Something you said which may have been wrong, or you were asked to demonstrate something and you didn't get it right, something like that. So from that level, they start coming down. So, okay, systemic examination, you couldn't answer. It will come down to general physical examination. And that time they'll ask you such questions just to test out how thorough are you, what kind of student are you, how well prepared are you. So in that case, if they ask you 5 causes of bradycardia, you should not slip up there. Okay, so that's your safety net. If the later questions you are not able to answer, the systemic examination questions you're not able to answer, they'll come back to general physical examination and ask you a few more questions. Those you should be able to answer, because then they should feel okay. It's a good student. Maybe the systemic examination part they couldn't answer, but at least these basic things they're answering. Okay, so make sure you're very thorough with GP. Okay, likewise, tachycardia. Tachycardia, everything is opposite. So it'll be fever. Okay, again, physiological. So always organize your answer. Physiological causes. That means exercise, anxiety. Whereas pathological causes, beta 2 agonists. It could be as a result of relative bradycardia in typhoid. Very good. Pawan says relative bradycardia. Relative bradycardia means we expect that for every 1 degree rise in 1 degree rise in temperature, 1 degree Celsius rise in temperature, we expect an equivalent rise in pulse rate by 10 beats per minute. If this doesn't happen, if the person seems to be quite febrile, 10 beats per minute, excellent, Kushali. So if the patient happens to be very febrile, 102 Fahrenheit, or let's say 41 degrees Celsius, and yet The pulse rate seems to be only 110 per minute. So we would have expected for 102. So if you take it from, let's say, the average is 70. So 70 for 98 Fahrenheit. Okay. So in that case, you will expect that for temperature of 102, it should have increased by 40. So which is quite equivalent, right? So if this kind of a proportionate response is seen, yet if let's say at 102 also they're having just a pulse rate of 100 per minute or 90 per minute or 95 per minute, which means relative to what is expected, it is less. That's called relative bradycardia. Okay, and relative bradycardia can be seen in typhoid. Very, very correct, Pavan. Can be seen in a lot of other disorders also, like leptospirosis, like dengue also sometimes, rickettsial fever. All these can cause relative bradycardia relative to the temperature. Okay. Yeah. So in terms of tachycardia, everything is opposite. Hyperthermia or fever both can lead to tachycardia. And then tachyarrhythmias can cause. So AV nodal blocks were causing bradycardia. Tachyarrhythmias. So atrial fibrillation, multifocal atrial tachycardia, atrial flutter, paroxysmal supraventricular tachycardia, any of the tachyarrhythmias, ventricular tachycardia, any of these tachyarrhythmias could cause tachycardia. Okay, hyperthyroidism or thyrotoxicosis can lead to tachycardia. Cocaine abuse can lead to tachycardia. Beta 2 agonists can lead to tachycardia. Okay, so blood loss. If there's hypovolemia, patient has cholera, diarrhea, vomiting, lot of volume loss, or if a patient has a trauma, then tachycardia is expected. Cardiac failure. Cardiac failure, you can't attribute either brady or tachycardia to cardiac failure. Cardiac failure, you may see a response as tachycardia, yes, but then you can't attribute directly to what do you say, heart failure or cardiac failure as a cause for tachy or bradycardia. It depends on what is the underlying cause. So they're not equivalent. So, for example, not all heart failure patients will have tachycardia. You will still have heart failure without tachycardia also. It's possible, especially let's say cor pulmonale patients with cor pulmonale, which is a right-sided heart failure. They may not have tachycardia. So you can't directly name it as a cause, attribute tachycardia to heart failure. Uh, MI, if you say anti-wall MI, yes, I can agree. Anti-wall MI, yes, they'll have tachycardia. Okay, like that. So rate is important. Questions based on it may be asked. Anemia and pregnancy, excellent answers. Physiological cause. Pregnancy is a very important physiological cause. Anemia is a pathological cause. Hyperthyroidism, pheochromocytoma. Yes, good answer, but rare condition. Pheochromocytoma typically expected to produce tachycardia, but it's a rare condition. Very good answer, but very good answer. Anemia, pregnancy, all absolutely correct. So these are all causes of tachycardia. So at least some five you should be there in your mind. In case I'm asked like this, I should be able to tell it immediately like that. Okay, so that's rate of pulse rate. Rhythm. Now, in terms of rhythm, either regular or irregular. Okay, when it is regular, if the pulse rate is normal, then a regular rhythm doesn't make too much of a difference. If the pulse rate is high or low, then rhythm becomes important. Whereas if it is irregular, always think of the first thing to look at when if it is irregular. So a finer point is whether it is regularly irregular or irregularly irregular. Okay, that's a very fine point. If it is regularly irregular, one of the examples, atrial fibrillation. Saima says atrial fibrillation, Kushali says PSVT. PSVT will be regular. Okay, PSVT we expect regular. Regular tachycardia is PSVT. Okay, VPCs. Okay, VPCs can be regularly irregular. Very good. So, for example, bigemini, ventricular bigemini, ventricular trigemini, quadrigemini. So they're coming, the ectopics are coming at regular intervals in between, interspersed between normal sinus rhythm. Then it is called, depending on how frequently it is. If one QRS, one sinus QRS is followed by each sinus QRS is followed by ventricular ectopic, then it is called bigeminy. Okay, if it is two QRS, now sinus QRS followed by the third impulse, which is a premature contraction, ventricular discharge, then it is called trigeminy. Okay, excellent. Malvika says sinus arrhythmia. Venkat said VPC, correct. Malvika says sinus arrhythmia. Sinus arrhythmia is a physiological cause for regularly irregular rhythm. So all of you, if you just check your own pulse, if you check your own pulse, take a deep breath. Take a deep breath in, then breathe out. Okay. You will notice among all of you that your pulse rate increases with inspiration. So I for I. I for I in terms of sinus arrhythmia. So increase in pulse rate with inspiration is called sinus arrhythmia. It's a physiological phenomenon. Okay. This is the same principle that applies to pulsus paradoxus also. Okay. Pulsus paradoxus, what happens? There is a widening of gap between the systolic pressure, blood pressure measured at expiration versus the systolic blood pressure measured at inspiration. So basically, during expiration, or rather during inspiration, the left ventricular output reduces. In order to compensate for that, the pulse rate increases. Okay. How to check clinically regular or irregular pulse? So Venkat is asking this question. It's not difficult. Are you able to predict the next pulse, next impulse? So now you're palpating the person's, let's say, radial artery. You felt the first impulse, you first felt the second impulse, you felt the third impulse. Now, are you able to predict the next impulse? So, and plus, is there a gap? And the gap between the successive impulses, is it maintained? Is it uniform? Is it fixed? If there's a fixed gap between successive impulses and you're able to predict the next impulse, then it is a regular pulse. If it is irregular, then again, two types. Either it's a regularly irregular, where the gap between two impulses is not fixed, yet you are able to predict the next pulse. Then it becomes regularly irregular. Okay, regularly irregular. Irregularly irregular is it's just random. You just cannot predict. There's no fixed gap. The gap between successive impulses is not fixed, and you're not able to predict when the next impulse is going to come because there's no pattern. There's no pattern that it's following. If you're able to figure out the pattern, even if it is irregular, you can predict the next pulse. Then that is regularly irregular. Regularly irregular happens in sinus arrhythmia. You can all test it yourselves. You can take deep breaths and watch your own pulse very regularly, or it can be irregular. Okay. So irregular is first thing you think of is atrial fibrillation. Irregularly irregular is atrial fibrillation. There are other examples. For example, multifocal atrial tachycardia. Maybe you guys don't need that much. Please remember atrial fibrillation. Irregularly irregular rhythm is atrial fibrillation. Regularly irregular, either it's pathological like VPCs, like bigeminy, like trigeminy, like quadrigeminy, or it's physiological like sinus arrhythmia. Okay, I for I. Keep that in mind. I for I. Correct. Kushali says atrial fibrillation. Yes. Okay. So rhythm. So when we check for rate and rhythm, we use the peripheral pulse. We use the radial pulse. Okay. And what is generally said is use three fingers to what do you say, to modulate, to examine for the radial pulse. So it's not so strict, but nonetheless, classically that was the teaching. Use three fingers. The initial one will help to stabilize the artery. The middle finger will actually appreciate the rate and the rhythm, and then the last the ring finger will help to modulate the flow and all that. So it's not so technical. You can use two fingers also. It's okay, two or three fingers, but try and make out the rate and rhythm in the peripheral pulse. The next two characteristics, the next two parameters, volume and character, need to be checked in the carotid pulse. Okay, so always look at the character and volume of pulse in the carotid. And how do you palpate the carotid? You use your thumb one at a time. Okay, not simultaneous. Don't go like this, palpating both carotids at the same time. You know where to palpate the carotid, no? Just below the bifurcation. So bifurcation generally occurs at the upper border of the thyroid cartilage. So upper border of the thyroid cartilage, technically you're supposed to palpate it against the transverse process of the C6 cervical vertebra, C6 vertebra. So any pulse in the body, you're supposed to palpate it against a bony prominence. So radial artery, you're palpating it against the styloid process of the radius. Okay, brachial artery, you can palpate it against the humerus. So technically, you're supposed to palpate it against a bony prominence. But carotid is so well felt, you need not have to go all the way. You need not have to put too much pressure and try and find where the bone is, the transverse process of the C6 is. You can, it is not a strict thing. Okay. Technically, you're supposed to, but you need not do it when you're actually palpating the patient. It'll be very uncomfortable for the patient also. But use your thumb. Thumb is preferred for looking or checking out the carotid impulse. It's at the level of the superior part of the thyroid cartilage, medial to the sternocleidomastoids. That is the difference between JVP and carotid pulse. JVP is lateral to the sternocleido, whereas carotid is medial to the sternocleido. So just with your thumb, one at a time, you can be able to appreciate the volume and character. Volume is what I already told you. Volume is nothing but pulse pressure. Okay, what you're only making out is the difference between systolic and diastolic. You're not really able to make out that the blood pressure is what. Supposing a person has a blood pressure of 160 by 110 and another person has a blood pressure of 120 by 180. The pulse volume in both these individuals will be equal because the pulse pressure is equal. The difference between systolic and diastolic is all you're feeling when you're checking for the volume of the pulse. It's equal if they have these blood pressures. Okay, so it's only indicating the pulse pressure volume. So you can get a high volume pulse when the pulse pressure is increased. So you know that there are certain conditions where pulse pressure is increased. They may be kept in your exams as a case. For example, wide pulse pressure. Where do you get wide pulse pressure? Very good. Venkat says AR. So wide pulse pressure is something that is seen in aortic regurgitation as a cardiac lesion. If you're thinking of cardiac lesion, aortic regurgitation is one of the causes. Otherwise, you can get it in several conditions: severe anemia, thyrotoxicosis, beriberi, all these hyperdynamic states. Okay, beriberi, Paget's disease of bone. All these can cause AV fistulae, anemia, malvicasis. Excellent. All these can cause wide pulse pressure. So when the systolic and diastolic are wide apart, then you will be able to appreciate a wide or you'll be able to appreciate a high volume pulse. So be careful, especially for postgraduates out there. When you're presenting the case and you say that you've already told that the blood pressure is, let's say, 120 by 80, and then while describing the pulse, you say it's a high volume pulse. No, they don't go hand in hand. There's a discrepancy. If you're going to say high volume pulse, you better be sure that the pulse pressure is wide. If the pulse pressure is not wide, don't say high volume pulse. They don't. I mean, it has to go hand in hand. If the pulse pressure is wide, then you can say high volume pulse. If the pulse pressure is low, then you can say low volume pulse. Pulse pressure is normal, then normal volume pulse. Okay, because pulse pressure is much more objective than the volume, but they're the same. They're the same. So you can't say that the pulse pressure is normal and then say high volume pulse or low volume pulse. If it's a low volume pulse, for example, aortic stenosis, the pulse volume will be low. In that case, you should get a blood pressure, let's say, of 100 by 80, like that, only 20 mmHg pulse pressure. And character. So remember, most characters, normal and abnormal. Sorry, Venkat is asking clinically how to know volume is by calculating pulse pressure. Correct. Absolutely correct. So like in let's say you're suspecting patient to have aortic regurgitation and you're looking for peripheral signs. No, in aortic regurgitation, look for peripheral signs of severe AR, and that is nothing but peripheral signs of wide pulse pressure. So whether it is Quincke's sign, Lighthouse sign, Becker sign, Muller's sign, Rosenbach signs, there are a lot of named signs. You need to memorize them. Pistol shot, very good. Owen says pistol shot. Traub's sign. A lot of names. Okay, of all of historical values. Where do we see such severe AR now? People get detected much earlier. People get treated much earlier. Hill sign. Hill sign is actually very important. That is to do with the Derosius murmur. Very good. Derosius murmur. Hill sign is very important, Venkat says. Gerard's sign, Gerard's spleen. So pulsatile spleen is Gerard's sign. Rosenbach's sign is pulsatile liver. Becker's sign is retinal artery. Landolfi's sign. There are a number of these signs. Okay, we have memorized it when we were students. You may be expected. You are expected to memorize it. It will help you. Okay, memorize them. Please memorize all the peripheral signs of aortic regurgitation, which are nothing but white pulse pressure because of white pulse pressure. Okay, Hill sign is very, very important actually. Hill sign actually has very good value. The rest, um, they're not seen anymore. Like there's something called Muller's sign. The uvula is supposed to be oscillating with each cardiac cycle. I mean that seeing that in this day and age will be very, very unusual, unlikely. Kushali said, the rose is mamas. Venkat says, locomotor brachialis. Excellent answer. Locomotor brachialis, you can definitely see. Locomotor brachialis, Hill's sign, these are of good value. Then there's Corrigan's pulse, very, very throbbing. It's called dancing carotids, very throbbing carotid artery. These may be, it's possible to see all this. But then water hammer pulse. Yes, very good answer. Water hammer pulse is one character which is not seen in carotid. You have to see it in the peripheral artery. So water hammer pulse, which is again a feature of white pulse pressure, is something that is seen in the peripheral sign. That is seen. Okay, I agree. Water hammer pulse is also seen even this day and age. DMAS sign. So uh, head bobbing with each cardiac cycle. Lincoln sign. Excellent. Very good. You should know because this will save you. So if you have an aortic regurgitation case, they'll ask you these. They'll answer. When you answer, it's like a checklist. Yes, student has answered this question. So the examiner has to give you marks. Plus, your confidence also increases. I was able to answer questions. So you should memorize all this. Put this to memory. Okay. Otherwise, apart from the white pulse pressure character, the everything else is usually measured in the carotid. You usually appreciate it in the carotid, and it's not so easy. Yes, we do discuss it, but it's not so easy to make out the character of pulse clinically. Okay. Anyway, what is the normal character of pulse? Normal, it is catacrotic pulse. Catacrotic. Okay. Pulse wave tracing. You should know what is pulse wave tracing. I mean, uh, if you know it, it's easier. You need not really know it, but if you know it, it's easier. Okay, we have two waves in systole. No, I'm sorry. That is the percussion wave, then the tidal wave, then followed by a notch, dicrotic notch, and the dicrotic wave. Okay, so this is how the waveform is generally very good. Uh, Venkat said catacrotic character, very good. Percussion wave, dicrotic notch, tidal wave. Excellent. Dicrotic notch comes after the tidal wave. Okay. And then comes the dicrotic wave itself. This is where the S2 happens. This is where the aortic valve closes. Aortic valve closes. Then you get another additional wave that's called the dicrotic wave. Okay. It'll be good if you can read up about this and know it, just in case the examiner tells, okay, draw and show how is the diacritic notch is always A2 tip to remember. Excellent. Yes, very good. Very good, Venkat. That's absolutely correct. So good to know, just in case you're asked. And of course, but clinically, to make out, okay, now it's the percussion wave, next is the tidal wave. It's not so easy, not at all easy, but good to know so that you can answer in your exams. Okay. What are the abnormal characters that you should know? Uh, for example, let us say pulsus bisferens. Pulsus bisferens is when you see twice peaking pulse both in systole. Okay, so like here, no, when there is a very prominent percussion and tidal wave, very prominent. So there's a twice peak. So twice peak in systole itself. Then that is called pulsus bisferens. So that you can see in aortic regurgitation. Aortic regurgitation, peripherally you get water hammer pulse, but in the carotid you can see pulsus bisferens. So severe aortic regurgitation. Okay, severe aortic regurgitation and HOCM. Excellent answer, Pavan. HOCM also you get pulsus bisferens. Very good. Two peaks in systole is indeed bisferens, Venkat. Very good. Very good. Likewise, dicrotic pulse. Dicrotic pulse is in contrast when there are two peaks again, one in systole, one in diastole. Okay. So twice peaking, but one in systole, one in diastole. So that is dicrotic pulse. Dicrotic pulse you get in hypovolemic shock. Very good. One peak in systole, one peak in diastole. Nick Venkat. So you get it in enteric fever, sometimes in sepsis, septic shock, hypovolemic shock. Definitely you can get. So that is dicrotic pulse. Okay. Likewise, anacrotic pulse. Anacrotic pulse again. It's a very slowly rising pulse, and that is something that is seen even in aortic stenosis. And there's a very typical type of pulse that is seen in aortic stenosis that is called pulsus parvus etardus. Parvus etardus. That is slow rising, low volume pulse. Pulsus parvus etardus. That is slow rising, low volume pulse. Okay. So these are certain examples of abnormal characteristics. Very good. Pulsus parvus etardus, slow rise, low volume, late peaking. Excellent answer. Venkat. So this is a finding in aortic stenosis. Peripherally, you can get water hammer pulse. Okay, water hammer pulse, you are supposed to, with one hand, palpate the radial pulse. Keep the other hand, your hand, examiner's hand, on the patient's forearm. Okay, so you got your hand wrapped around the wrist, feeling for the radial pulse with one hand, and your other hand on the patient's forearm. So you hold it ready with the hand by the side of the patient. So hold, appreciate the radial pulse also, and keep your palm on the other hand palm on the forearm. Vishal is asking between radial and brachial. Yes, correct. Correct. So the other hand should be on the forearm between the radial and brachial. Excellent. Whereas one hand is already on the radial, wrapped around the wrist, looking at the radial. Collapsing or Corrigan. Correct. Corrigan sign is the prominent carotid. Collapsing pulse or water hammer pulse. Very good. That is what you're trying to appreciate. So first, the patient has the hand with you holding with your two hands. You're holding the patient's hand in these areas, and the patient has the hand by the side. And then you suddenly lift the hand up. Make sure they don't have any shoulder issues. You suddenly lift it, and then you try and appreciate that you'll feel a rebound impulse. Okay, both in the radial, and if it's severe enough, even in the forearm, you'll be able to appreciate. So that is called water hammer pulse. So it's a feature of severe aortic regurgitation, which means the pulse pressure must be very wide. So this is another point. If you're going to say the patient is having a water hammer pulse, make sure that the person's pulse pressure is wide. Okay, if you can't say blood pressure is 120 by 80 and say the patient has a water hammer pulse. That means all of us who have 120 by 80, we should also be having water hammer pulse. That's not true. Correct. So if you're saying water hammer pulse, check the blood pressure, ensure that the pulse pressure is wide. Okay. Yes. Next is condition of the vessel wall. Condition of the vessel wall is a very important finding, especially in, let's say, middle-aged people. So you got a person who's in 40s or 50s, and person has developed a stroke or a myocardial infarction or has past history of MI, something like that. Okay, in that case, you're wondering, does the person have atherosclerosis? Is he a smoker? You can look at the condition of the vessel wall. It will be thickened. So normally when you're trying to roll the radial artery beneath your fingers, no, you're not able to make out the arterial wall. You can't delineate the dimensions of the arterial wall, right? It's the artery, although you can feel the pulse, but you can't feel the vessel wall when you're trying to roll. If you're able to feel the vessel itself, you feel that the vessel wall is palpable underneath your fingers when you're trying to roll, that means it is thickened. If it is thickened, it is sclerosed. It is sclerosed, it is atherosclerosed. So atherosclerosis will make you feel the condition of the vessel. I mean, will make you feel the thickened vessel wall will be palpable, easily palpable. Okay, so atherosclerosis makes you be able to palpate the thickened vessel wall. So in atherosclerosis, what are the additional findings you'll see? You will see locomotor brachialis also. So where do you look for locomotor brachialis? You look for it here. So what you do is, what is normal condition of the vessel wall? It's not palpable. So you can't feel the vessel wall, no? So it's not palpable. So even if you say the condition of the vessel wall is normal, it's accepted. Or you can say the vessel wall is not palpable. Either of these two is okay. But if you're able to feel it's thickened, either you comment that it is thickened or that the vessel wall is palpable, that means it's abnormal. So vessel wall is palpable or it's thickened means it's abnormal. You can choose to say it's normal or that it is not palpable. Both are okay. That is about condition of the vessel wall. Locomotor brachialis. If you're thinking patient has atherosclerosis, look for this also. Okay. And how do you look for it? You flex the arm at the elbow. I'm sorry, flex the upper limb at the elbow, and then try and make out the brachialis, the brachial artery pulsations. Normally, you're not able to see it, but then if person's vessel wall has thickened, no, then you can make out the pulsations of the brachial artery, locomotor brachialis. So it's not just seen in wide pulse pressure; it's also seen in atherosclerosis, locomotor brachialis. Then one more finding you can try and look for is arcus. So corneal arcus and thickened vessel wall and locomotor brachialis, all are features of atherosclerosis. Okay. And then radial and radial and radiofemoral delay. Xanthomas, excellent. Xanthelasma, xanthomas. These are additional findings. Correct. Absolutely right. So corneal arcus, xanthomas, xanthelasma. Xanthelasma is generally periorbital, where there'll be deposition of cholesterol. Xanthomas depends. Hypercholesterolemia can lead to xanthomas in the tendons. So tendon xanthomas are more are seen in high LDL conditions. Okay, absolutely correct. And then delays. So whether it's a radial delay or radiofemoral delay. So what you generally have to do is you need to make sure that they are at the same level. For radial delay, what you can do is you can keep the arms like this and hold their pulse. Okay, so they should be equidistant from the heart. If you're looking for radial delay, clinically you're not supposed to you're not supposed to appreciate any delay between appreciation of both radial pulse. They should be felt at the same time normally. If there's a significant delay, if you're appreciating that one radial pulse, you can appreciate it earlier than the other. That means something is wrong. Okay, either there is an arterial disease or there is a thrombus somewhere in that particular arterial distribution, proximal to where you are feeling the pulse. That means the radial means it's proximal to that radial pulse, like that. So there must be something wrong. Cervical rib also is a possibility. Very good, Pawan. So there might be a thoracic outlet obstruction. So something is wrong if you are able to, or it may be a coarctation of aorta also. So there's something called preductal coarctation. In case of preductal coarctation, there may be a radial delay also. So you have to keep them equidistant from the heart. Likewise, radiofemoral delay, you ask the person is supine, you keep the hand by the side of the patient, and that brings it as close to the femoral artery. So radial artery is as close to the femoral artery as possible. So and then you palpate it simultaneously. So you're palpating the radial artery against the styloid process of the radius. Femoral artery, you can palpate it against you externally rotate the lower limb. So lower limb, you externally rotate it. Then you can palpate the femoral artery against the head of the femur. So whenever you're trying to make out the femoral artery, you can, it's at the mid-inguinal point, no? The femoral artery is at the mid-inguinal point. So when you externally rotate the lower limb, the head of the femur comes a little more prominent. So that's why you can palpate it easily against that. Okay, so simultaneously, radial and femoral simultaneously. So there should be no significant appreciation of delay. If it is getting delayed, then again something is wrong. It could be a post-ductal coarctation or even preductal coarctation if it's the right radial versus right femoral delay. Okay, and or it could be vasculitis, so something that is affecting the artery. Could be a thrombus, it could be a thoracic outlet obstruction, like Pawan said. So all these are possible if there's a delay. Okay, so these are all possibilities. Of course, in your exams, they may ask you preductal versus postductal. Excellent, Venkat. So preductal means it will be it's possible that it has paired the coarctation has occurred just after the I mean, you'll be able to appreciate that the right subclavian is fine, but the left subclavian has gotten affected. The blood flow through the subclavian, left subclavian has gotten affected because of a preductal coarctation. So all these are possible questions, and this is the meaning of what we want you to look at when you're trying to look at the pulse. Okay. This was in depth about blood pressure and pulse. Maybe I should speed it up a little bit because there's a lot to cover. Okay. The rest, respiration. Rate is important, rhythm is important. Rate and rhythm and patterns. Okay, rate and then pattern. So they say thoraco-abdominal, abdominothoracic. So for women, it is thoraco-abdominal. Excellent, Pavan. So all peripheral pulses felt equally and bilaterally. You you can the better statement would be corresponding pulses are felt equally. Okay, you don't expect all pulses to be equal. You expect the corresponding pulses to be equal. So the radial on one side, radial the other side, brachial on one side, brachial on the other side. So corresponding pulse, peripheral pulses felt equally. Excellent point, but excellent point. We cover all systemic examinations in detail like this, or how many days? Okay. Well, this was just on request that I'm doing. One of the students had requested to do a session on general physical examination. That's why we're doing this today about all systems. It will take some time, I suppose. I'll see how we can accommodate all system examination. Fine. And that's what I'll speak to Kishan sir also how we can plan it out. Let's finish today's session first. Corresponding peripheral pulses are felt equally. That is fine. I'll do it, Venkat. I'll do it. I'll have to plan it out. That's all. So corresponding pulses, peripheral pulses felt equally is a more appropriate term. So for example, dorsalis pedis on one side and dorsalis pedis on the other side is equal. That makes more. What do you say? It's more sensible. Okay, but very important point. Good point. That was. Yeah. So pattern and abnormal patterns like we discussed. Biot's breathing is irregular. Kussmaul's breathing is hyperventilation. So when there is an increase in rate of respiration, it's called tachypnea. When there's an increase in rate and depth, then it's called hyperventilation. So who hyperventilates? I mean hyperventilation. Sorry, hyperventilation. So who is going to hyperventilate? Either it's out of anxiety or panic, which is sort of acceptable. It's okay. That's like Venkat said, or it's as Shanti says, it's decay. So acidosis. So during any metabolic acidosis, there's going to be a compensatory respiratory alkalosis. So as part of the compensatory respiratory alkalosis, the person's breathing will increase in depth and rate. That's called hyperventilation. That's called Kussmaul's breathing. If it is because of acidosis, then it's called Kussmaul's breathing. Kussmaul's breathing. Okay. How do you make out that the person might be having acidotic breathing? You can look at, I mean, of course, clinically, it'll be difficult. Okay, if Venkat says fruity odor, excellent answer. Fruity odor will apply to diabetic ketoacidosis. That's absolutely correct. But what if it is uremic? Then you, then you might say the breath is having a uremic breath. That's also correct. But in general, any acidotic person, if you are if when you check their oxygen on the probe, on the saturation probe, I'm not talking about clinical exam, not for your exam, but in the emergency room, the person seems to be breathing fast, and then you check their oxygen level, the oxygen level is fine. So which means possibly it is hyperventilation. If you are having difficulty in making out that is this Kussmaul's breathing or is the patient having tachypnea, is the patient having breathlessness, person will deny, I'm not having breathlessness, but the person is breathing fast. Then you're wondering what's happening. You check their oxygen level, it's fine. Then one of the possibilities could be they're hyperventilating because they have an underlying metabolic acidosis. Okay, that's Kussmaul's breathing. Then there's Cheyne-Stokes breathing. So Kussmaul's is one. Okay, Kussmaul's is one. And then Cheyne-Stokes breathing. Cheyne-Stokes breathing is going to be, should we admit them? Venkat is asking for a patient who has metabolic acidosis. Absolutely. You need to find out what is the cause of the metabolic acidosis. No, so most often, if the person it has gone to that stage where it's so obvious that they are hyperventilating, that means their metabolic acidosis is probably severe. Better to admit them because metabolic acidosis, when the pH comes down, it's going to affect a lot of things, including cardiac functions. So the person might develop shock. The person might go into hemodynamic dysfunction. Nikhil is asking, is it a rule that all females have thoracoabdominal type of pattern? Yes. So that is generally how the orientation of the muscles, respiratory muscles is. It will generally be thoracoabdominal for women and abdominal thoracic for men. Normal pattern is like that. Abdominal thoracic in men. Correct, Venkat. So there can be situations where it will be purely thoracic or purely abdominal. For example, per patient with massive ascites, their abdominal muscles are of not going to be of any use. Their abdominal muscles are like stretched to their maximum, so they may not. Diaphragmatic palsy, excellent. So diaphragmatic palsy also, you'll hardly see any abdominal movement at all. It will be purely thoracic. Massive ascites also will be purely thoracic. So there are certain situations where you can see either purely thoracic or purely abdominal. Purely abdominal, you can see if the person is having paralysis of the intercostal muscles, so intercostal nerve palsy. So in that case, you can see only purely abdominal breathing. So there are possibilities like that. Otherwise, what by convention, by the way the muscles are oriented, thoracoabdominal is for women, abdominal thoracic for men. Okay. Cheyne-Stokes breathing is where the rate seems to, uh, so there'll be an initial period of uh, where the depth of respiration is gradually increasing, then peaking, and then followed by a reduction in the depth of respiration, followed by almost no respiration. So that's called alternating periods of apnea or hypopnea with hyperpnea. Okay, it's called hyperpnea, increased rate and depth of respiration, followed by decreased rate and depth of respiration. So they're alternating, and in fact, there may be periods of apnea also in between. So this kind of a pattern where there is an increase, then followed by a decrease, then an increase, waxing and waning, waxing and waning. That's called Cheyne-Stokes breathing. That's something that is seen in heart failure patients, sometimes also seen in patients with raised intracranial pressure. Okay, although Biot's breathing is more typical of Biot's breathing is total haphazard, random, unpredictable pattern of breathing, irregular breathing. Irregular rhythm to pulse is atrial fibrillation. Irregular rhythm to breathing is Biot's breathing. Okay, so these few things you can you should not expect in your exam. There's no way a patient with Biot's breathing should be kept for your exams. But then you should know what is Biot's breathing. What are the patterns? What are the abnormalities you can expect in respiration? Types of periodic breathing. Excellent. Types of periodic breathing like Biot's or Cheyne-Stokes. Okay, and then temperature. So temperature, again, you are allowed, if you have a thermometer, you're allowed to use it as an additional thing. It's not purely clinical. If you want to check purely clinical about the temperature, then you use the back of your, the dorsum of your hand. Okay, you don't use your palm, it's too thick. You use the back of the dorsum of the hand. Venkat is asking bradypnea. Yes, bradypnea is also a possibility, especially opioid poisoning. Um, Sometimes you can get it again in raised intracranial pressure also. So something that is either causing malfunction of the respiratory centers in the medulla by pressure or by chemical nature. That is opioids generally. Okay, we used to get a off and on we used to get patients of opioid overdose. There's a tablet called maybe I should not tell you guys. Okay, there's a particular composition of tablet which contains opioids, which can be abused. Okay, so a lot of times patients used to abuse it, take a lot of it, and then they would present totally bradypneic. The respiration like hardly any diaphragm, hardly any chest wall movement at all. But we knew this was quite no, it's not LSD, and I'm not going to tell it also. It won't be correct. Okay, but we knew that it was prevalent in the area that youngsters used to get misled and indulge in all this. So as soon as we gave them naloxone is the opioid antagonist. No? So as soon as we give the naloxone, the breathing starts. So a lot of times, what used to happen, like initially, we'd be so worried and we'd be about to intubate the patient. So just in the process of intubation and inserting the endotracheal tube, by the time the naloxone is brought and they start giving the naloxone, just moments later they'll totally become active. They'll pull out their own tube also. Yes, naloxone generally it comes as 400 micrograms. We used to give it as stat dose of 400 micrograms to reverse that opioid overdose. So bradypnea also can happen. So bradypnea could occur because of any reason that is. So it's a long process actually. We have the respiratory centers in the medulla. Then we have the cervical spinal cord, especially the C3, C4, C5 segment, which form the roots for the phrenic nerve. The phrenic nerve will go and innervate mainly the diaphragm. Okay. And then we have the lungs and the chest wall surrounding the lungs. So problems anywhere in this can lead to bradypnea. Either the medulla center has been damaged. It could even be because of low BMR. So if the BMR itself is low, why breathe fast? So hypothyroidism is also another cause for bradypnea. Uh, opioid uh, uh, opioid overdose can cause respiratory center suppression, depression. Uh, Um, tumors could cause it, intracranial hemorrhage could cause it. So anything that has caused suppression of the medullary centers for respiration. Then there's a lesion in the spinal cord. Okay, transection of the spinal cord, for example. It'll be very difficult for the person to survive. But let's say there's a compressive myelopathy that is not yet fully compressed, but in the process of compressing the spinal cord. So in that case, phrenic nerve uh, will not be functioning normally. So in that case, respiratory rate would come down, bradypnea would happen. Okay, any problem with the diaphragm? Diaphragm is a skeletal muscle. It's innervated here, so there's a neuromuscular junction. Anything that targets this neuromuscular junction, whether it is myasthenia gravis, whether it is snake bite, cobra venom, crate venom, all these can target this junction, cause bradypnea. Okay, and then finally the lungs themselves. So if the lungs are inelastic, like for example emphysema patients or chronic bronchitis patients, inelastic lungs, they are not capable of breathing fast. They're always going to be slow. So you can get chronic respiratory acidosis because the lungs are so slow in COPD, in chronic bronchitis especially. The slow lungs will tend to retain carbon dioxide most of the time. So they'll have low oxygen, high carbon dioxide, type 2 respiratory failure, chronic metabolic acidosis. So that is a feature of COPD. Okay, or there's a problem with the chest wall. So chest wall issues, including muscles as well as the ribs. So let's say if the person has very painful ribs, then also they'll not want to breathe much. Every time they breathe, if there's a multiple rib fractures, they'll breathe slow. So bradypnea will happen. Okay. So bradypnea, a number of things could go wrong and lead to bradypnea. Okay, otherwise temperature. Temperature, looking at it using the dorsum of the hand to look at the temperature. Otherwise, you have to use the thermometer. If you're using oral or are you using axillary, you have to add 1 degree to the temperature when you measure it in the axilla. Okay, when you measure it in the axilla, you have to add 1 degree to get the representative actual body temperature. Because axilla is slightly cooler than the core temperature. So it's 1 degree. There is a difference of 1 degree. Rectal is 2 degrees. For axilla, it's 1 degree. You have to add when you're using a thermometer to check the temperature in the axilla. Okay. Then the questions on fever, on hyperthermia, that's quite commonly asked. Difference between fever and hyperthermia. For sublingual, you need not have to add. It's okay. When Venkat has asked for sublingual, you don't need to add for sublingual. Sublingual temperature for axillary, you need to add 1 to get sublingual. For rectal, you need to add 2 to get sublingual. It's like that. Okay. So questions can be based on fever versus hyperthermia. What are the causes of hyperthermia? Hyperthermia could be heat stroke, could be as part of malignant hyperthermia. Yes, define fever. Excellent, Venkat. Patterns of fever. We love to ask it as examiners. I mean, this is where you get bailed out. Okay, you couldn't answer the questions on systemic examination. It'll be brought back to this, and then you'll be asked define fever. Tell the difference between fever and hyperthermia. Tell the different patterns of fever. What is the difference between continuous fever, remitting fever, uh, remittent fever, intermittent fever? What are the difference between these three? Then any other specific patterns do you know? Do you know what is Pell-Epstein fever? Do you know what is saddleback fever? Do you know what is stepladder fever? Where do you get relapsing fever? Like that. So these things save you. If you know all these, you get saved in case you get stuck somewhere further down. Okay, so define fever. Yes, fever is the rise in body temperature in conjunction with the hypothalamic thermostat or temperature set point. The rise in body temperature in conjunction beyond normal. The rise in body temperature beyond the normal range in conjunction with the hypothalamic thermostat or hypothalamic temperature set point. That is fever. If it happens without the conjunction of the hypothalamic thermostat, it's called hyperthermia. Okay, hyperthermia can be seen in heat stroke, can be seen in malignant hyperthermia, can be seen in neuroleptic malignant syndrome. All these are potential causes of hyperthermia, which means it's not the hypothalamus that decided that the body temperature should rise. The body temperature rose without the permission of the hypothalamus. So, which means it's not fever, it's hyperthermia. So, this is a potential question. And like you said, like Venkat said, define fever, patterns of fever. So remember, if the fever is touching the baseline in 24 hours, anytime during the 24-hour period, touching the baseline is intermittent. It is intermittent. If the temperature, this is fever, okay, intermittent fever. If the temperature never touches the baseline in 24 hours, it doesn't touch the baseline at all. And yet the variation is less than 1 degree. So no touch baseline, but okay, not touching baseline, but variation of the temperature is less than 1 degree, then it is continuous. If it is more than 1 degree, then it is remittent. These are all standard Viva questions, like Venkat said. How useful is it for me to know whether the person has continuous, intermittent, remittent? Not as useful as maybe it was in the past, where we had very limited modalities of investigations. Now it's a lot more investigation based. So, but this still carries value, especially in your exam. So you need to know it. Okay, and then the patterns of fever. So Pell-Epstein fever, you get it in? Who can tell me? Which disease do you get Pell-Epstein? You will get a febrile period. Very good. Pawan says Hodgkin. So you'll get a febrile period followed by Epstein, sorry. Followed by a few days of afebrile period. Generally, it'll be 3 to 4 days of febrile, then almost a week of afebrile. Then again febrile, then again Venkat says Hodgkin's. Excellent. So Pell-Epstein is Hodgkin's lymphoma. Where do you get saddleback fever? Saddleback fever is also similar to this, but you won't keep repeating. You just have one spike, then afebrile, then again another spike, then again afebrile. So saddleback fever is dengue. Excellent. Venkat and Kushali and breakbone. Pavan says breakbone fever. Breakbone is the description for the pain that it causes, the back pain, severe back, low back pain that dengue causes, but not the temperature pattern. Temperature pattern is saddleback fever. That's also correct. Breakbone fever is dengue, but not with relation to the temperature. Okay. Where did you get tertian? Tertian fever every 48 hours. Step ladder fever, excellent. Step ladder. Step ladder, you get it in? Typhoid, excellent. Rose spots, pea soup diarrhea, very, very good. Very good, Venkat. Typhoid. Step ladder. Tertian, you have tertian, you have quotidian, you have quatern. Quotidian means faggot sign relative bradycardia also. Very good, correct. Quotidian means, yes, so malaria. So you get tertian, vivax, ovale, or falciparum, Plasmodium falciparum. Whereas these are called benign tertian. This is called malignant tertian. Then quotidian is every 72 hours. This is 48 hours. Tertian is 48 hours. 72 hours. That is malaria. We don't have it. It's only in Africa. India doesn't have malaria. And then there's something called quatern. Quatern is every 24 hours. That you can get in Knowlesi. Plasmodium knowlesi. So remember, we have 5 plasmodia. Okay, Knowlesi is the one that causes every 24 hours. So questions based on these can be asked. If you're prepared with these, it'll be good. You'll be able to answer questions. Every question you answer raises your confidence. and makes a better impression with the examiner. Okay, so besides the vitals, you have to look at, make sure you comment on these, please. Okay, so it makes a very good impression. If you, even if the patient just has an IV cannula, please mention it. Or they may have anything else, nasogastric tube, oxygen delivery device. This itself can be nasal prongs, or it can be a Hudson mask, that's face mask, simple face mask, or it may be a non-rebreathing mask, or it may be a Venturi mask, it may be a high flow nasal cannula, anything, something the patient may already be having. Okay, and then you should make a mention of it. Okay, if the patient has an IV cannula, make a mention that there's an IV cannula placed in the left forearm or left dorsum of the wrist, wherever it is. Nasogastric tube is in situ. IV cannula I've repeated this, IV cannula, but or a central venous catheter is in situ on the left side, right side. Urinary catheter, indwelling urinary catheter in situ. Make a mention. Okay, it completes your general physical examination. Beyond this, you should go for head-to-toe examination. Now, as I said, pickle is very, very important, no doubt, but don't restrict yourself to only pickle. Please go beyond it. Is it relevant to your provisional diagnosis at the end of history, or should you be looking for something more? That's what you need to decide. Okay. When talking about head-to-toe examination, of course, you can look for alopecia. Alopecia, more of a, I, it's not okay. Alopecia may be, I don't know. I'll tell you one thing. In men, no, when men have a lot more alopecia, uh, thallium, okay, yes, thallium poisoning and all, okay, thallium overdose, as Venkat says. When men have alopecia, uh, the chances that their testosterone levels are high is more. Okay, because alopecia generally is because of testosterone, and that's not a good thing, not always a good thing for men, because the higher the testosterone, the higher the atherosclerosis chances, the higher the risk of atherosclerotic cardiovascular diseases like coronary artery disease. Okay, so patients who are having alopecia, um, you have to watch out there. They have to watch out for their heart. Okay, so otherwise, there are diseases, or there are pathological entities which can produce alopecia. For example, non-scarring alopecia, you can get it in SLE. You can get alopecia areata is an entity in its own which causes alopecia. Again, non-scarring alopecia. Okay, so but that's more of a dermatological discussion. May not give you too many clues with regards to your examination cases. Okay, syphilis, yes, syphilis can also may cause alopecia, no doubt. Okay, but otherwise, if you look at the eyes, what do you want to look for? You want to look for pallor. So you may be asked by the examiner, okay, demonstrate how you look for pallor. What you need to do, you need to lower the lower palpebral conjunctiva. Palpebra means lid, eyelid. So lower palpebral conjunctiva is where you need to watch or observe for pallor. You ask the person to look up, the patient to look up, and you pull down the lower eyelid and expose the lower palpebral conjunctiva. This is the best site to look for pallor. Adequate sunlight, Venkat says. Will this video be uploaded on YouTube? Kushali, yes, I think it will be. As far as I know, it will be uploaded on YouTube. You can watch it later also. It's okay. Let me check if it's currently live or what. So, as Venkat said, yeah, it's live. It's there on YouTube. So, as Venkat says, I think it will be. So there's some comments on YouTube also. I'll come to the YouTube comments later if you guys excuse me for now. I'll continue on Zoom. Okay, so you look for this is the best site. You can see the blood vessels directly. Okay, so if you want to make out whether the person has pallor or not, you can. If you should be seeing red vessels here. Okay, you're not. If you're not seeing, that means the vessels don't have enough hemoglobin. The patient is pale. So person having pallor, you can easily make out in the lower palpebral conjunctiva, the best site. There are other sites. Which are the other sites to look for pallor? You can look for it in the tongue. You can look for it in the palms. Nails, okay. More than nails, the palms are a better site. And if the person is very, very pale, you can make it out in the skin and the face itself. And when they walk into your OPD or your clinic, you can easily make out, okay, this person is pale. Okay, they're having a very sullen look. Okay, it's called sullen look. So that means the person is having very low hemoglobin. Sometimes you can get pallor, but there's no anemia. So pallor most often means anemia. But there are conditions where you get pallor but no anemia. Which are the conditions where you get pallor but hemoglobin is normal? Normal hemoglobin. Look in natural light, Pawan says. That's true, but it's more applicable for icterus. This natural light is more applicable for icterus. When you want to look for icterus, you may be confused. Especially in the olden days, it used to be the halogen bulb, the yellow light. So you should not be able to make out correctly. So it was always advised, examine icterus in natural light. That's true today also. But pallor also, it's correct. Of course, adequate lighting is important if you want to really examine, but not necessarily natural light. But there are conditions where person appears pale like this. The amount of blood seems to be less in the conjunctiva, yet the hemoglobin is fine. So this you can get it in shock. The hemoglobin may be fine, but it's not getting delivered to the conjunctiva. So patient with shock, especially hypovolemic shock, uh, it could be that the patient appears pale but is not anemic. Venkat says albinism. That's correct. If you're looking only at the skin, then albinism, even secondary adrenal insufficiency. So secondary adrenal insufficiency, what can happen is the problem lies in the at the level of the pituitary. Alabaster skin. Excellent. Alabaster pale skin, Venkat says. So that is secondary adrenal insufficiency because ACTH is gone. ACTH, remember, comes from pro-opio-melanocortin. So there is something for pro-opio, then there's something for melano, and there's something for cortin. Right? Cortin is ACTH. Melano is MSH. So MSH is lost. This is the precursor for ACTH. POMC, pro-opio-melanocortin, is what leads to ACTH production. Also leads to melanocyte stimulating hormone production. So if melanocytes are not getting stimulated, the skin will become alabaster like pale skin. That's the description. Or albinism also. Okay, so patient may have pallor but no anemia. Hypothyroidism could also lead to this kind of a picture. Hypothyroidism anyway leads to a pallor, but also may lead to pallor without anemia also because of the pale skin. Okay, so that's what you want to look for in the eyes. Ask them to look up and lower the lower eyelid to try and appreciate pallor. Icterus is the opposite. Icterus you want to appreciate in the uh, uh, bulbar conjunctiva. Bulb meaning the eyeball. So bulbar scleral conjunctiva. This conjunctiva overlying the sclera. So that is where you want to appreciate icterus. So you want them to look down, and you will try and raise the upper eyelid. So that is where how to make out the icterus in a patient. This is very important. To make it out in natural light is important, more important for uh, icterus. Very correct, Venkat. Ask them to look down. So, the differential diagnosis for icterus will be muddy sclera and carotenemia. Okay, the difference between carotenemia and icterus is that carotenemia doesn't affect the sclera. It affects only the skin. The person may appear to have yellowish skin, but not the sclera. That is carotenemia, beta carotenemia. Too much of carrots. Okay, which has beta carotene. Otherwise, muddy sclera is the other differential. Muddy sclera, check both eyes at a time. Icterus and pallor. Never look each eye at a time. Once my professor told. Yes, I suppose that's not wrong. And whatever professors tell, you have to follow because they'll be your examiners. So these are all old conventions which served a purpose at one point of time and therefore are being followed now also. And no harm in following any of these conventions. So good to continue. As I was saying, muddy sclera can cause discoloration of the sclera, but generally it will be in the exposed part. The unexposed part will not be so discolored. So that is the opposite of icterus. Icterus, the unexposed sclera will be, or the conjunctiva would appear more yellowish than the exposed. Okay, so Medisclera, exposed is more discolored. In actual icterus, the unexposed is more discolored. That's because in the exposed part, UV radiation is acting to uh, clear up the exposed part icterus. That's why you use phototherapy for patients, for neonates who have icterus, jaundice. No, for neonatal jaundice, treatment is phototherapy by exposing to UV radiation. The bilirubin gets conjugated and eliminated. So that's why the exposed part in icterus is generally less discolored. If you are suspecting icterus, always you may not notice it. You may not make out in the exposed part. You have to check for the unexposed sclera. Ask the person to look down and raise their upper eyelid. Okay, it's ophthalmos. This is again a finding you can get in palmar crease for high level. Yes. So if the person is having very high, Shankar says, very high, I presume high bilirubin levels, you can make it out in palmar crease is what you're saying. Absolutely correct. So skin also will be very obviously discolored if the patient is having high level of bilirubin. Exophthalmos would indicate proptosis, would indicate that means the lower limbus would be quite obvious. Lower level of the limbus would be of the cornea would be very obvious, which generally it's not, right? Generally, you're not able to make out. Theratoxicosis, excellent. So a number of named eye signs are there. Maybe from ophthalmology point of view, that is more important, but not so much from medicine. You just exophthalmos or proptosis is if you are able to tell, that's enough. If suggesting a thyroid disorder like Graves' disease, specifically Graves' disease, thyrotoxicosis, specifically Graves' disease. Exophthalmos means Graves' disease. In Graves' disease, they'll have goiter, they'll have exophthalmos also. In the eyes, you can also make out. Venkat says Von Graf signs. Yes, Von Graf's Dalrymple, Stellwag, a lot of named signs, maybe from ophthalmology point of view, more important, not so much for us. Yeah, so conjunctival suffusion. That's the opposite of pallor, no? Pallor, conjunctiva, especially the palpebral conjunctiva is pale. What if the conjunctiva is suffused? Suffused meaning it is reddish. Excellent answers. Venkat says dengue and polycythemia. Excellent answers. So dengue also, because of capillary leakage, leakage through the capillaries of the conjunctiva, there is suffusion. So dengue, correct. Then polycythemia, excellent. Obviously, if anemia is leading to pallor, then polycythemia must be leading to suffusion. Opposite. Same story with the palm. So palm is pale in anemia. Palm is erythematous. Palmar erythema is seen in polycythemia. Okay. Yeah. So one more thing you should remember is leptospirosis can lead to very, very typical feature of leptospirosis, conjunctival suffusion. So you can try and look for these when you're examining the eyes. Okay. Just a few points I am missing. Weil's disease, excellent. That's correct, Venkat. So Weil's disease you can try and look for. You can look for a lot of other things, but few points at your level. Suffusion just means congestion. Just another term for congestion. Conjunctival congestion. Okay, they're all the same. Suffusion. Suffusion means basically extra blood flow. Congestion. Injection. Conjunctival injection. This. Okay, all the same. Meaning it's red. Red conjunctiva. Okay, just few different words. Conjunctivitis. Yeah, conjunctivitis means inflammation. Not necessarily, it's a local problem. That means conjunctivitis, it's a local problem. Systemic problem causing redness of conjunctiva. Then suffusion, injection, congestion. You can choose to say whichever you want. They all mean the same thing. Okay. Head to toe for oral cavity. Yeah. So what else do you look for in oral cavity? Pallor. So dorsum of the tongue, you look for pallor. Dorsum of tongue. Okay. And icterus, you generally make out in the ventral surface of the tongue. Ventral surface of the tongue. Whereas cyanosis, you make out in the margin of the tongue. Margins of the tongue. So in the tongue margins, cyanosis. Even under surface, you can make out cyanosis. Icterus in the ventral surface, and dorsum of the tongue, you look for pallor. Okay. Cyanosis, very important. If you are able to make out cyanosis in the oral cavity, in the oral mucosa, it is central cyanosis. So remember, cyanosis is of two types, central and peripheral. The difference being, in central cyanosis, there is going to be oral mucosa being discolored, bluish discoloration. Oral mucosa is involved, whereas oral is not involved in peripheral cyanosis. Why is central cyanosis happening? It's because of hypoxia. Why is peripheral cyanosis happening? It's because of poor blood flow. Okay, either blood congestion, peripheral congestion of blood, stasis of blood, or poor blood flow in general. Okay. So one of the differences is the oral mucosa cyanosed or not? If the oral mucosa is cyanosed, it is central cyanosis. Should we check for palpable or bulbar conjunctiva? Ashwin is asking, conjunctival suffusion is generally evident. See, when you want to make out uh, icterus or conjunctival suffusion, it's better to have a white background. So you can make it out in the bulbar conjunctiva itself. Okay, when you want to make out the opposite, what should be red is not red, then you check for in the bulbar conjunctiva. What should be white is now red, or what should be white is now yellow, then it is easier to appreciate. That is in the bulbar conjunctiva. Okay. Yeah. So this is the difference between central and peripheral cyanosis. Try and make out. Oral ulcers, you can try and appreciate. Thrush, you can appreciate. Especially if, let's say, a patient of asthma has been using inhaled bronchodilators, which also contains steroids. So inhaled corticosteroids. If the person has been using inhaled corticosteroids, you have not instructed them, or they were unaware, or they did not follow your instructions that they're supposed to rinse their mouth and throat after each use of this inhaled corticosteroids. This is because gargling, excellent Venkat. You're supposed to instruct them, once you use the inhaled corticosteroid, you need to rinse your mouth or gargle. Otherwise, you might get local infections, including fungal, which means Candida. Thrush is Candida. So my question to you would be, can you remove candidiasis when it forms the pseudomembrane? The pseudomembrane can be seen in other conditions also, in the oral cavity, in the tonsils and all that, especially in even streptococcal you can see it, even in diphtheria also you can see it. But can you remove candidiasis pseudomembrane? Can you remove? The answer is yes, you can. No. Answer is yes, it's Candida, no? In Canada, you can remove. Okay, it will bleed. There will be bleeding, but you can remove it. Okay. Whereas in other conditions, streptococcal, diphtheria, and all that, you can't remove it. The pseudomembrane cannot be removed. It will be attached, adherent. Candidiasis, thrush, you can remove it. Okay, so you can remember it as can. Okay. Then there are other forms of candidiasis, hypertrophic candidiasis. Sometimes no, you won't see the whitish thrush. You'll just see a very red tongue. So erythematous form of candidiasis is also there. Somebody who has a very red tongue, and then they give you history they've been using beat well correct, but even candidiasis, I'm saying candidiasis can be in the form of hypertrophic lesions. It can be in the form of thrush. It can be in the form of just erythema also. So if they give you a history of using inhaled corticosteroids, you should suspect candidiasis, as in the oral cavity. Okay, face. There are certain diseases which have typical faces. So hepatic faces, that means cirrhosis. Okay, in cirrhosis, what can you get? You can get hollowing of temples. You can get pinched nose and hypertrophy of the parotids, plus fetor hepaticus. All this you can get as part of hepatic facies or cirrhosis. Okay, from a distance only. If you see enough patients, no, from a distance as they're walking into the OPD, or as you are walking into the ward where they are admitted, you can from a distance only make these diagnoses. Hepatic facies. If you've seen enough alcoholic cirrhosis, which unfortunately in our country we do have a lot of alcoholic cirrhosis. Cushingoid facies. Cushingoid facies is moon-like faces, rounded faces. There'll also be a buffalo hump. The skin will be quite thinned out. Okay, they may have a little bit of hirsutism also. So increased hair, especially down the in front of the ears. So on the face, maybe even including the mustache and beard area for a woman. There also hair may be more, but also on the sides you should look for. Okay, in the bang area. And moon faces, buffalo hump, thinned out skin. On the abdomen, there'll be striae. There'll be wide purplish dehiscent striae. Uh, uh, Limbs will be thin, but central obesity will be there. All these lipodystrophy features, all these will be there in Cushingoid features, including Cushingoid facies. Okay, that's not uncommon in India, unfortunately, because of steroid abuse. So many patients take steroids for different reasons. For even topical steroids, if they apply too much of topical steroids, also it can cause Cushingoid facies. Very high dose. Okay. Inhaled corticosteroids also. High dose inhaled corticosteroids can also produce Cushingoid facies. Okay. COPD. COPD facies, what will you expect? Something like this, pursed lipped breathing. So it's almost like whistling, but like this, like that. They'll have a pursed lip. It's almost like the lips are pursed. Okay. So COPD patients will have especially emphysema patients will be very lean. They would have lost a lot of muscle mass. That's why BMI, in patients with the COPD, the lower the BMI, the worse the disease. The higher the BMI, the better for them. Okay, so there's something called board index. When the BMI, it's inversely proportional. So when the BMI is, directly proportional. The prognosis is worse when the BMI is lesser. B stands for BMI. O stands for obstruction. D stands for dyspnea. And E stands for exercise capacity. That's the 6-minute walk distance. Anyway, you don't need this theory. You don't need these things. Just remember, lean patients will generally be emphysema. I mean, COPD patients who are lean are generally emphysema patients. That's why they're called pink puffers, right? They're lean. They've lost a lot of muscle mass. They're able to breathe. They don't have sinus. They don't have hypoxia, but they're having to breathe quite fast. Emphysema. Chronic bronchitis patients, they are blue bloaters. They're cyanotic. They are hypoxic. Chronic hypoxia, chronic type 2 respiratory failure, metabolic acidosis. Respiratory acidosis. And they are bloated. They're bloated because of heart failure. The hypoxia has led to pulmonary hypertension, which has led to cor pulmonale, which has led to pedal edema and fluid retention. Okay, little too much theory, maybe. I'm sorry, but just remember, blue bloaters, pink puffers. Blue bloaters is emphysema. Blue bloaters is chronic bronchitis. Pink puffers are emphysema. Watch out for this pursed lip breathing. That is COPD patient. Okay, COPD patients, look at their lips. Their lips would be almost like purplish because of smoking. If it's a smoking related COPD, look at their lips. It'll be purplish. Look at their nails. If they're active smokers, no. If they're right-handers or left-handers, it depends on that. Which hand do they hold the cigarette or the BD? So those nails would be nicotine stained. Look for those. Look for those changes. You'll notice that the nails are nicotine stained. And if they have really quit recently, if they have quit recently, you'll be able to make out the proximal aspect of the nail would be normal color. The distal to that, there'll be nicotine staining. So you can actually make out since when did they quit the smoking. If let's say the proximal 2 mm of the nail is normal color and the rest of the nail is having nicotine staining, that means they've quit since 2 weeks. That's because the average growth of nail is 1 millimeter per week. So how much ever is free of nicotine proximally, that much time they have not smoked in the last 2 weeks. Okay, it may be opposite also. It may be that the distal 2 mm is normal and all the proximal is nicotine stained. That means those distant 2 weeks they had not smoked. After that, every week they've been smoking or every day they've been smoking. So you can make out. You should look for nicotine staining in their nails. COPD patients, smokers especially. Mitral facies, there's something on mitral facies. Because of severe mitral stenosis, there'll be cyanosis, central cyanosis, there'll be telangiectasias. In the malar area, there'll be telangiectasia. Okay, and that is mitral facies, severe mitral mitral stenosis. This is mitral stenosis. Okay, hypomimia. Any idea? Earlobe crease, excellent. Earlobe crease. Earlobe crease is an indicator of What is it? What does it indicate, Pawan? Correct. An increased risk for cardiovascular complications, atherosclerotic cardiovascular disease, coronary artery disease, basically. Frank's sign. It's called Frank's. Excellent. Venkat says Frank's sign. Correct. So yeah, so that's something you can make out. SLE, you can make out a malar rash, butterfly rash. It's called erythematous rash on the malar area. Okay. Uh, any idea what is hypomimia? Mask-like. Excellent, Venkat. Mask-like faces. So can you tell me some causes? So many causes are there. Expressionless, expressionless faces. Parkinson, Pawan says. Excellent answer. Parkinson's. So Parkinson's is one. Then Sjogren's. Why will Sjogren's have mask-like faces? Anything else? So either you really reason for malar rash in mitral stenosis. It's not malar rash. In the malar area, there'll be telangiectasia. So in severe mitral stenosis, the what do you say? Um, Cardiac output is ineffective. So left atrium to the left ventricle flow is reduced so much, the effective cardiac output is so low that there'll be peripheral vasodilatation. So the capillaries in the peripheries are also dilating. So there's going to be telangiectasias in the malar area. This along with cyanosis. So because of cyanosis, they will have because of poor peripheral blood flow, low cardiac output. There is there is going to be central cyanosis. I'm sorry, the central cyanosis because of mitral stenosis, along with telangiectasias in the malar area. So that's just because of low cardiac output. Pawan says psychiatric disorders. Excellent. Why not psychiatric disorders? What else? So you can get it in scleroderma. Skin is too thick, so they're not able to express. In fact, unfortunately, their face may be stuck in a position. They'll be like this. So they'll have a lot of difficulty in opening their mouth also fully. Almost trismus-like. There's nothing wrong with the jaw. It's just the skin is too thick. Okay, so scleroderma, bilateral facial palsy, facial nerve palsy. LMN or UMN. You need your muscles of facial expression to be activated by the facial nerve. No? So imagine bilateral facial nerves damaged. So you can't express. Pellagra. Why will pellagra cause expressionless faces? It will cause the 3Ds. If you include death, then even 4Ds. Dermatitis, diarrhea, and dementia. Otherwise, niacin deficiency, no? Not expressionless faces. Botox injection. Okay. Maybe overdose of Botox injection. Otherwise, very difficult. Castle's necklace. Excellent. Yes. Castle's necklace in pellagra will be there. Okay. So these are all the causes of hypomimia, expressionless face. Okay. Can you guys identify? Oh, I'm so sorry. I'm so sorry. Uh, oh, I did not realize this. I'm so sorry. Yeah, so sorry. Can you guys make out what is the faces here? This particular child, adenoid faces. Not quite. Okay, maybe I will just erase a little bit. You can see the face, no? I mean the nose, no? Very good, very good. One of you has identified. Pawan has identified thalassemia. Thalassemia, the depressed nasal bridge and malar prominence. There's actually some amount of frontal bossing also. It's difficult to make out in this view. Chipmunk faces, excellent. Venkat has, Venkat has told it. It's chipmunk faces that you get in thalassemia. Correct. So some things are like spotters. Elfin faces, Ashwin says elfin faces. Elfin faces, yes, low set ears, short chin. These you can get an short stature also, small face. All these you can get in elfin faces. Elfin faces, number of disorders. One of them is Williams syndrome. Excellent. One of them is Williams syndrome. That is hypercalcemia along with aortic stenosis, supravalvular aortic stenosis. Venkat has told it correctly. So look out for these examination findings. In the neck, look out for lymph nodes. Examine lymph nodes. JVP, carotid pulse. You should know what is the difference between JVP and carotid pulse. What are the differences? So how do we write this? JVP and carotid pulse. First of all, site. This is lateral. JVP is lateral to the sternocleidomastoid, whereas this carotid is medial to sternocleidomastoid. Okay. Then what are the waves per cardiac cycle? Per cardiac cycle. If it is carotid, you are going to get 1:1, whereas you'll get multiple waves. Excellent. Collapsibility. So is it compressible or not? Can you obliterate or not? Compression or obliteration. You can obliterate a vein because its wall is not very strong. It doesn't have too much pressure inside it. But for an arterial pulse, you can't really obliterate it so easily. So when you apply pressure, JVP will get obliterated, but not carotid. What about variation? Can it have variations? Yes, JVP will have variation with respiration, with position, whereas arterial pulse, not so. What happens in respiration to JVP? JVP always reduces with inspiration. With inspiration, normally JVP should reduce. If it doesn't reduce, instead with inspiration, fall less than 10 mm. Yeah, fine. If there's a particular value below, I mean, maximum limit to which it should fall, I'm not aware of it, but normally it should fall. Basically, there should be a fall in JVP with inspiration. That's correct, Pawan. But in case the opposite happens, if there is a paradoxical rise in JVP with inspiration, yeah, as Venkat says, 10 cutoff is usually for pulsus paradoxus. With expiration, the systolic blood pressure is 10 higher than the inspiratory systolic blood pressure. And then it is, if this gap is 10 more than 10 then it is pulsus paradoxus. That is a blood pressure finding actually, though it's called pulsus paradoxus. First of all, it's not paradoxical. It's an exaggeration of normal phenomenon. And on top of that, it's not a pulse finding, it's a blood pressure finding. So you have to measure the systolic blood pressure. As you're lowering the pressure, no, in the cuff, first you hear the carrot cough sound in expiration, only in expiration. And then as you lower the pressure, you start hearing it both inspiration and expiration, the carrot cough sound. So this difference is usually less than 10 If it is more than 10 it's pulsus paradoxus. Kussmaul sign, excellent. In JVP, Kussmaul sign is when the JVP is paradoxically elevated with inspiration, seen in late right heart failure. Restrictive, if you meant constrictive pericarditis, restrictive cardiomyopathy, yes, both these can cause it. Okay. And then lymph node examination. I think lymph node, I'll leave it to surgery because surgery can explain about lymph nodes. You have to stand behind the patient. If you're examining for cervical lymph nodes, examine from behind the patient. Try and make out right from 1A, 1B, so submental, submandibular lymph nodes, jugular-digastric, that's level 2A, 2B, 2C. I'm sorry, level 2, 3, 4 lymph nodes. That is the upper jugular-digastric, middle jugular-digastric, and lower jugular-digastric lymph nodes, group of lymph nodes. Then try and make out the supraclavicular lymph nodes. Obviously, and there's something called scalene lymph nodes. Scalene lymph nodes, they are seen between the two heads of the sternocleidomastoid. Ashwin's asking how to say A wave, C waves in JVP. Clinically possible. Yes, A and V you can make out. C is very, very difficult. C is very, very difficult unless there's a pathological, very prominent CV wave like in tricuspid regurgitation, which is very, very uncommon. Primary tricuspid regurgitation itself is uncommon. So to make out CV wave will be very uncommon to make out C wave. A wave, yes, and V wave, yes. So anytime you observe JVP, no, it will go up and down twice. For each pulse that you feel, or if you are palpating the apex, for each apical impulse or for each peripheral pulse, you will see the JVP will go down, up and down at least twice. Generally, the descent is more prominent in JVP, whereas the carotid, the outward pulsation is more common. Descent is more common in JVP, or more prominent, I mean, more prominent in JVP, the descent. But at least twice it will go up and down. In between, it should be having a C wave, which is very difficult to make out clinically. You need pulse wave tracing again to try and make out. But otherwise, clinically, you can still make out A and B waves, positive waves, and the X and Y descents you can make out. Okay. Okay, alcoholic stomata, parotid enlargement, Dupuytren's contracture. Parotids will be enlarged as expected in alcoholics. Dupuytren's contracture. Venkat is asking, HPC antigen is also not seen in blood, but why did that come? Yes, hepatitis B core antigen is not something that is seen in blood. Is not seen in. Is not seen in C is not seen. Okay, like that you wanted to say. Okay, very good, nice. When you try and think laterally like this, it helps. It helps to revise because there's so much in medicine to learn. It's so volatile also, so voluminous and volatile. It helps if you can think laterally like you are, Venkat. Good. So yeah, Dupuytren's contracture, generally Palmer aponeurosis will be fibrotic, and that will produce contracture. Generally, it affects the ring finger or the little finger like this. At the PIP, the proximal interphalangeal joint, there'll be contraction like this or like this. Why parotid is enlarged in alcoholics? It's to do with I'm also not entirely certain, but there is going to be an increase in secretions of the parotid gland whenever one consumes alcohol. It does increase the parotid secretions or salivary gland secretions in general. Um, the exact reason even I'm not sure, but that is a definite association. There's a definite association between alcohol consumption and parotid enlargement. I'll have to find out the exact reason and I'll get back to you. I'm not aware of the exact reason. Okay. Okay, so this is important for you guys. Cirrhosis patient, you should know what are the peripheral signs of liver cell failure. These include parotid enlargement again, spider nevi. Spider nevi are where you'll see one central arteriole, uh, which is surrounded by branching capillaries. So the capillaries that are branching out from the central dilated arteriole. Okay, so that's why it looks like a spider and the head body of a spider and the legs of the spider. This is because of vasodilatation. So because of vasodilatation, the arteriole is dilated and its end branches are radiating from it, and that's what gives it that appearance of a spider due to estrogen. Excellent. Estrogen has a vasodilatory effect. That's why you get spider nevi. That's why you get Palmer erythema. Palmer erythema is because of peripheral vasodilatation. And peripheral vasodilatation also occurs in any case in cirrhosis. Um, that is to do with the splanchnic and peripheral vasodilatation happens because of increased nitric oxide levels. Excellent. Spider nevi can be seen in pregnancy also, Venkat. So that's why estrogen does play a role. That's why they say the cutoff is 5. If you see more than 5 spider nevi, then it is definitely pathological. In women, you may be able to see spider nevi, 1 or 2 odd spider nevi because of estrogenic effects. And especially in pregnancy, you might see less than 5. But if it's more than 5, it's pathological, like in cirrhosis. That's what is said. Okay, Palmer erythema, not just in polycythemia, but also in cirrhosis of liver. This is Palmer erythema. Okay, you can make out the erythema in the palms, no? A cirrhotic patient. Okay, leukonychia. Leukonychia is Terry's nails, that is white nails. That's because of hypoalbuminemia, because low albumin, which is again because of cirrhosis. So white nails, Terry's nails. Gynecomastia, again because of high estrogen levels. Testicular atrophy will also be there because of high estrogen levels. Testicular atrophy, all thanks to high estrogen. This is all in men. Okay, gynecomastia in men, testicular atrophy in men. No. Lindsay's nails in CKD. That's CLD, that's chronic liver disease, that's Terry's nails. Okay, Terry nails in CLD. Lindsay's nails in CKD, correct. Not in CLD. Okay. The rest is theory. Why estrogen is high? It's theory. Estrogen is high because of escape of dehydroepiandrosterone, which is generally metabolized in the liver because liver is cirrhotic. This dihydroepiandrosterone goes to the periphery in the fat. Aromatase acts on it and converts it into estrogen. Therefore, you get all these effects. Okay. A few examination findings you should look for if the patient is anemic. So let's say the patient is anemic and you get such pale palms where palmar creases are also less pigmented than the palm themselves. So normally if you check your own palms, the palmar creases are more pigmented than the surrounding palm. But if you get the opposite, the palmar creases are less pale or as pale as the surrounding skin, that means the hemoglobin value is expected to be, HB is less than 8 gram per deciliter. It's a what do you say, a theoretical correlation, not very common practically to see palm creases which are so pale. Even if the hemoglobin is 6, 5 and all, we don't generally see palmar creases being more pale than the surroundings. But theoretically, it's possible that if this is true, the HB must be less than 8. Okay, any idea what this is? This is the retina. This is the fundus. What is this depicting? You're seeing a pale center. This is the retina. Pale center. Okay, I'm sorry. I should show here. There's a pale center surrounded by hemorrhage. This is the fundus actually. This is the optic nerve head. This is the rod spot. Very good. So rod spot. So rod spot are not specific to infective endocarditis. Rod spots can be seen in severe anemia also. So if you happen to have a fundoscope and you know how to use it, you can actually make out severe anemic patients may have rod spots. So it's not specific to infective endocarditis. B12 deficiency also. Yes, very good. Severe anemia in general can have rod spots. Okay, what is this? Koilonychia, excellent. Spoon-shaped nails. So Koilonychia, Platynachia, these are indicative of, Pavan has told it correctly, iron deficiency anemia. Okay, so watch out for excellent Venkat, terminal stages of iron deficiency anemia. Correct. So watch out for history of blood loss, history of barefoot walking in the fields, history of pica, wanting to eat mud, wanting to eat rice grains. I'm sorry, rice grains, raw rice grains. All these you have to watch out for. Sorry. Ankylostomodial. Yes. Sorry. Why is it not working? Okay. Yes. Restless leg syndrome. All these can be associated with iron deficiency. And iron has non-anemic manifestation. Iron deficiency has non-anemic manifestation also, you should know. It is important for heart functioning. So heart failure patients, refractory heart failure, you should rule out iron deficiency anemia. Hair loss can occur because of iron deficiency anemia. So very important. Non-hematological significance of iron. Okay, here you can make out knuckle pigmentation. So knuckle pigmentation, strawberry red tongue, these are additional findings suggestive of B12 deficiency. So if you get a patient with anemia, try and look for these additional findings. How's the nail? How's the knuckle? How's the tongue? These can give you clues to what may be the potential cause for the anemia. So B12 deficiency, hyperpigmentation of knuckles, beefy red tongue, megaloblastic anemia. Excellent, Venkat. Instead, let's say you see, this is what is Lindsay's nail. Lindsay's nail is proximally pale, distally red. Half and half nail. It's called half and half nail. Half pale, half red. Half and half nail, Lindsay's nail, along with puffiness of the eyes. Probably the blood pressure is very high. This is indicative of anemia. If this patient is pale, which and has all these features. CKD, excellent. CKD, chronic kidney disease. That's what's causing the pallor in this particular patient. What if you find medial aspect of the leg ulcer is there? Patient is pale and has recurrent ulcers in the leg. Calciphylaxis. Okay, good. Calciphylaxis can occur in CKD patients, especially if you give them calcium supplements because they already have high phosphate. If you keep giving them calcium into phosphate, calcium phosphate products. Varicose veins, you're right, Shankar. But I meant it with respect to anemia. Venkat is saying Burger's disease. Absolutely correct. They'll have it a little more distally. This is medial aspect of the leg is unusual, but okay, it can occur even in Burger's disease. But hemolytic anemia, okay, hemolytic anemia, sickle cell disease, hemolytic anemias can manifest with pallor and leg ulcers, recurrent leg ulcers. Okay, so these are certain general physical examination findings, hand-foot syndrome. Okay, in children, hand-foot-mouth syndrome. They won't be so bad. The ulcers will not be so bad in hand-foot-mouth disease. Whereas in sickle cell and hemolytic anemias, you can get quite bad ulcers in the medial aspect of the leg. Okay, sickle cell crisis, Shantis. Absolutely correct. What about icterus? As I said, you need to ask the patient to look down and expose the unexposed part of the bulbar conjunctiva and look for overlying the sclera and look for icterus in that, especially in very good daylight. That helps. So what is the difference between faint icterus and deep yellow icterus? If it is deep icterus, no, should always suspect obstructive jaundice. If the patient has obstructive jaundice, so they will have additional features. Very good. Hemolytic is when you say lemon yellow tinge. Faint lemon yellow tinge you get in hemolytic jaundice. Excellent, Venkat. So you will never get deep jaundice. Never get deep jaundice in hemolytic anemia. You cannot. Liver, as long as the liver is fine, no, you will not get deep icterus in hemolytic anemia. Hemolytic. Whereas obstructive, you will have to suspect obstructive jaundice if the person is having very deep yellow, greenish yellow icterus. Okay. Along with that, they'll have history. They'll have scratch marks. They may have xanthomas, xanthelasmas in obstructive jaundice. Okay. Scratch marks. They'll already have pale history of passing pale stools, pruritus. Yes. Scratch marks on examination. Xanthomas, xanthelasmas. That's again because of high cholesterol. So remember, liver is what eliminates cholesterol, no, through the bile. So if that is obstructive, cholesterol gets retained, and therefore hypercholesterolemia occurs. Clay-colored stools, absolutely correct. So this is what you expect in icterus. Okay. They may ask you what are the types of jaundice. So pre-hepatic, hepatic, post-hepatic jaundice. Okay, cyanosis is when there is bluish discoloration of skin and mucous membrane due to the quantity of reduced or deoxygenated hemoglobin exceeding 4 gram per deciliter. Okay, so this is the definition of cyanosis. Same like portal hypertension and acute kidney injury classification. Yes, correct. Portal hypertension is a little more complicated. Like there is in the intrahepatic also there is pre-sinusoidal, sinusoidal, and post-sinusoidal causes of portal hypertension. And then there's prehepatic and posthepatic. Very correct, Venkat. And acute kidney injury also. Yes, very good. So pre-renal AKI, renal AKI, post-renal AKI. Okay, how can you comment on pallor in jaundice patient? Pallor in jaundice patient, it can be confusing, especially when the icterus is quite deep, like in obstructive jaundice. But finally, you can look at the other sites also. But finally, the blood vessels should be visible. Even if the person has a lot of yellowishness, the blood vessels should be still visible. You should be able to make out whether they're having pallor or not. Most often, very high bilirubin levels, the disease must be so severe, they should have pallor also. They generally will have associated pallor. So, because of a severe disease. So you should be still able to make out the blood vessel in the the palpebral lower palpebral conjunctiva to see if it's red enough or it's less red, which means the patient has pallor. Okay. Yeah, sorry. As I was saying, that question will apply here. Severe anemia, you will not be able to make out. You can't make out cyanosis. No cyanosis, because you need a minimum hemoglobin level for it to exceed the reduced hemoglobin level to exceed 4 gram per deciliter. If he has no hemoglobin to spare, if already the overall hemoglobin itself is very low, you may not be able to make out cyanosis even if the patient is hypoxic. Okay, so cyanosis may be missed if the patient has severe anemia. Otherwise, central versus peripheral, I told you, central, there is oral mucosal involvement, whereas peripheral, this is oral mucosal plus, let's say, digits and limb, whereas peripheral, it's only the oral mucosa is spared, it's only the digital. Okay. How is it relieved? It's relieved by giving oxygen. This is relieved by warming the periphery. Okay. Just a 2-minute break. I'm getting a call. Just a 2-minute break and I'll rejoin. Okay, sorry. Let's resume. Coming to clubbing. Clubbing is when there is an obliteration of the onychodermal angles. It's characterized by a distal bulbous enlargement of the uh, the fingers and the toes. So a distal and bulbous enlargement of bulbous enlargement of the distal ends of the fingers and the toes. That is called clubbing, and it is characterized by obliteration of onychodermal angle. That means the nail and nail bed angle, onychodermal angle. Okay, so we have the nail and we have the nail bed. So normally this angle should be at least 170 degrees, not more than that. Okay, maximum 170 degrees. This is the, sorry, let me show it like this. Yeah, so this is the distal phalanx, this is the middle phalanx, and this is the onychodermal angle. Normally it should be 170 degrees maximum. If this angle gets more and more obtuse, if this angle becomes 190 degrees, 200 degrees, like that, if it keeps becoming more and more, then it's called clubbing. Okay, onychodermal angle. Yeah. What you may be expected to tell is what are the grades of clubbing and then the causes of clubbing. So grades of clubbing, 1, 2, 3, 4. And in that also, one is the simplest one. Yeah, obliteration of onychodermal angle. You can also try and display the Lowy bond angle. It's called Lowy bond angle, the diamond shaped angle. When two nails are held in opposition, they're supposed to make out a diamond shaped space between them. But then if there is clubbing, that Lowy bond angle will be lost. It's also called Shamroth sign. So Shamroth sign, Lowy bond angle being lost, all the same. Or you can make out fluctuation of the nail bed. So this nail bed, normally, if you appreciate in your own colleagues, you'll be able to appreciate that there is normally also very little amount of nail bed fluctuation. So you're supposed to fix the digit, and then with one finger on each side, you're supposed to apply pressure on the nail bed. So on the nail bed, when you apply pressure, there'll be very slight amount of fluctuation normally also, very, very slight. But if it is more, so increased fluctuation in the nail bed, this is again feature of grade 1 clubbing. Grade 2 is when there's an increased anteroposterior curvature. So increased anteroposterior curvature or longitudinal curvature, that is called grade 2 clubbing. If there is anteroposterior plus uh, transverse curvature, so if there is longitudinal and even axial curvature increase, that is grade 3 clubbing. Grade 4 is the changes are not no longer restricted only to the digits, it's also in the wrist. So enlargement of the wrist, enlargement of the ankles, that is because of it's called hypertrophic osteoarthropathy. So yes, hypertrophic osteoarthropathy, or if it because the very well known cause of grade 4 clubbing is CA lung, that's why it's called hypertrophic pulmonary osteoarthropathy, as Venkat says. So hypertrophic osteoarthropathy or hypertrophic pulmonary osteoarthropathy. So you can't make out grade 4 clubbing only in the nails. You need to look at it in the wrist and the ankles. Okay, so grades of clubbing is important. You should know. And then causes of clubbing. So respiratory causes of clubbing, cardiovascular causes of clubbing, and then the other causes of clubbing. So respiratory causes of clubbing, you have all the suppurative lung diseases. That means bronchiectasis. Very good. COPD is never a cause of clubbing. If it's a chronic smoker who has developed COPD and now has developed clubbing, you should suspect a CA lung rather than COPD. Very good, Venkat. COPD is not a cause of clubbing. That is the commonest mistake students make. If they're asked what are the causes of clubbing, the first thing they say end up saying is COPD. COPD is not a cause of clubbing. CA lung is a cause of clubbing. Suppurative lung diseases are causes of clubbing. Respiratory cause of clubbing. CA lung. If you want to say mesothelioma also, it's okay, but not COPD. Okay. Bronchiectasis. Bronchiectasis anyway is suppurative lung disease. Interstitial lung disease. Idiopathic pulmonary fibrosis. All these can cause clubbing. Yes, suppurative lung diseases like bronchiectasis, lung abscess, empyema thoracis. All these can cause clubbing. Okay, what are the cardiac causes of clubbing? These include infective endocarditis. Subacute infective endocarditis can cause clubbing. Subacute, not acute. Subacute infective endocarditis. Then cyanotic congenital heart disease is very good. Cyanotic congenital heart disease or post-Eisenmegerization. Acyanotic post-Eisenmegerization or a cyanotic congenital heart disease. Congenital heart disease or atrial myxoma. These are the causes of cardiac causes of clubbing. Then what else? You can have hepatopulmonary syndrome, which is a complication of pulmonary hypertension that can cause clubbing. Syringomyelia is a neurological cause for clubbing. Syringomyelia. So these are all causes of clubbing. You may be expected. Inflammatory bowel disease, excellent. Primary sclerosing cholangitis, inflammatory bowel disease. These are causes of primary biliary cholangitis also can cause clubbing. These are causes of clubbing. Okay. Respiratory, GI, neurological, cardiac, and there's something called pseudo clubbing also because of increased subperiosteal resorption, like in hyperparathyroidism or in scleroderma because of Raynaud's phenomenon. There can be subperiosteal resorption leading to pseudo clubbing. Okay, unidigital, yeah, traumatic. So traumatic cause of clubbing can be there because of unidigital. Yeah, that should be okay for clubbing. Lymphadenopathy, I'll just skip this one. Okay, I think you'll be taught this in surgery anyway regarding lymph nodes. Edema. Okay, so pedal edema applies to person who is ambulatory. If the person is bed bound, then you'll have to look for sacral edema. And first thing you want to try and make out is there pitting or not? Is the pitting is there? That means it's a more recent edema and also it is most likely a transudative edema. Otherwise, if there is non-pitting edema, you will start suspecting whether it's a very chronic edema which has now become indurated, and this can be seen in conditions like mixed edema or lymphedema. Lymphedema in turn can be because of number of causes, including filariasis. Okay. Mm, what else? This is what you may be asked. If it's a bedridden patient, where you look for edema. And then how do you check for edema? You need to apply pressure for at least 30 seconds and see if the pitting happens. Before you lift your finger, at least 30 seconds you should have kept your, and how much pressure you should apply? Enough for your nail to blanch, just enough for your nail to blanch. That much pressure, not too much. Okay, don't have to dig in with your thumb. It'll pain, especially if you're appreciating it on the shin or in the leg, in the foot. You need to be little gentle. Okay, don't go too hard. That should be okay. So unilateral edema, if you see unilateral lower limb edema, think of causes like varicose veins, think of cellulitis, think of DVT or lymphedema or lymphedema. Asymmetric or unilateral means these are the causes. How much depth? There's no over medial malleolus. Yes. You can go over any bony prominence. Basic principle is if it's a displaceable fluid, the fluid will get displaced as you apply pressure, and that pressure should be for 30 seconds. The time is more important. Depth is till your nail blanches. Okay, that's the amount of pressure you're supposed to apply. So just enough pressure till your nail blanches. That much. Then you hold that pressure for 30 seconds and then remove. Then see if the pitting is stayed back. The pitting doesn't stay back. It's a non-pitting edema. Then you have to think of mixed edema, lymphedema, scleredema, angioedema. All these are non-pitting. Scleredema, angioedema. Okay. So general physical examination in a bedridden patient, what do you look for? Last two slides. I'll finish after this. So for what may happen, you might have a patient who has paraparesis or a hemiparesis who's bedridden. So you have to look for certain additional GPE findings. So very good. DVT, pressure source, and presacral edema, maybe if the person has a cause for anasarca. Otherwise, these two are very, very important. Okay, DVT and pressure source. Very important to make out. And remember, in such patients, they'll most likely also have a Foley's catheter or a nasogastric tube, or they may have a diaper. So if they have a diaper, look for diaper rash because of eczema, because of wetness. Okay, acute gastroenteritis, try and make out dehydration features. So dehydration meaning tongue must be dry, capillary refill time must be more. Venkat says UTI and aspiration pneumonia, excellent. Yes, you have to look out for features of aspiration pneumonia, UTI also, contractures also. Depends on the neurological condition status. Okay, you have to make out if the tongue is dry, the eyes are sunken, the capillary refill time is more. Axilla is dry, excellent. Yes, these are the. So basically, the suggestion is don't go for only pickle. Look if that pickle applies to your case or not. Acute gastroenteritis means what? Why will I suspect pallor if it's an acute gastroenteritis? No, I will rather suspect dehydration. So GP is pickle most of the times. Yes. So the purpose of saying pickle was, or uh, following pickle was, at least those six things you don't miss out on. You otherwise, if you're randomly asked to do head-to-toe examination, you'll be lost. Okay, what do I look for? What do I look for? Instead, at least these six things you should be looking for anyway. That's how it was started, but you should try and go beyond it. So these six things I look for, but since I was suspecting acute gastroenteritis, I want to look for dehydration. Since I was suspecting patient to have a stroke with hemiplegia or paraplegia, I want to look for DVT. like that. So you should go for more focused examination. So an asthenic patient like this, you will look for nutritional deficiencies. So all the fat soluble vitamins, water soluble vitamins, everything you will want to look for. Look for pallor, look for upper circumference, excellent, yes. You look for features of cachexias. So you'll look for features of vitamin deficiencies, mineral deficiencies, and so on. So you have to individualize based on what either your impression after history was, or your impression on general appearance itself. From this appearance itself, you'll want to look for certain features on examination. Okay, I think that brings us to the end of today's session. I'm sorry it went on for a little too long, but in summary, my main message would be don't stick to just the pickle. Don't forget to mention the supporting devices, the supporting whether instruments which are there in the patient in situ. Do not miss. Make a mention of those and vitals. Okay, and mention the vitals first. And be prepared for questions based on general physical examinations. They're going to save you in your exams, because if you don't answer even these, then it's a problem. But if you don't answer more complicated questions, but you are able to answer these, you're able to clear these, then it's okay. You're you're okay. Okay. Systemic examination is mainly about the format and demonstration, not so much about interpretation. Okay, so okay, Venkat. Since you're asking inter-system examination, especially seen as power reflexes. The thing is, these are more like practical things, no? Difficult to teach um, on this kind of a platform without hands-on, without a video. I'll see what I can do, but I'll try and see how best we can discuss these also, and I'll discuss with the Kishan sir also about how best we can try and cover these.
No, in December anyway, sir, we are planning to have a like offline class, most
Excellent, correct,
preferably in Bangalore in auditorium, where
correct.
we'll be demonstrating all these signs and tests on a, live patient, maybe a volunteer, if not a real patient. So that we especially I what I liked the most about today's session was you are stressing more on the basics and basics. Okay, like you repeatedly mentioned, it's not the like final diagnosis or the final results that matter, but the approach is matters most for at least for UG level. We don't expect them to make a big diagnosis or to get all the signs right. No, that's not our expectation. But as an undergraduate who is going to be a doctor tomorrow, we want them to approach in a proper manner. We want to them to like you just mentioned, if they approach rightly, then everything comes in a like a proper manner, and the chance of they becoming right is very high. So why pickle? You are answering so well. Like at least that much they go in a order. Otherwise, they will be lost. So excellent class. I thoroughly enjoyed the entire 2 hours of session. I never found it was like kind of boring or like why this session, something like that. No, even at this level, I also learnt a lot, and I enjoyed the class. And yes, in November end or mostly in December, Venkat, we'll be having in Bangalore also, which will be last year also we did it in Bangalore, and it was a huge success. We are all capacity was 400, but we got some 500 students who were sitting even in the like outsides of the hall to attend the class, and it went on really well for 2 days. So this year we are planning to have it in Bangalore, preferably, so that connectivity is good for all the students to like from the out of state also. We got students last year to Bangalore, which kind of considerably less connectivity is there considered to other cities.
Right.
So and which will be live streamed also on YouTube for other country students. We have so many attended today also on YouTube also. For them it will be live streamed, but I always prefer to have these practical classes on a offline basis rather than like sir was mentioning now through videos and all like explaining bit difficult. So live demonstration, like so that you can put yourself there in the examiner's position, and you can imagine for yourself. Sometimes when you're in doubt, we may ask you to come forward and do those tests for yourself. And what I do usually in my surgery classes, I make you do on mutually to each other. To, for example, sir was repeat telling about lymph node examination, cervical lymph node. I make the two students to do on each other axillary lymph node examination, cervical lymph node clubbing demonstration, so that you will not find any difficulty during examination suddenly when you go there. So excellent class, sir. And so many holiday, I was receiving so many messages on my WhatsApp, even third year PGs asking for continued classes. Sir, this will be, hi sir, when will practical classes? It will be very helpful for final year PG residency students also, because majority of them have exams in December, January, whole India. If possible, please launch a practical course, which will be helpful for PGs. So, sir, a lot of demand for your classes, Akshay sir. So, we'll do it. Definitely, we'll do it this time. Okay. Preferably a weekend, Saturday, Sunday or so. It will be helpful for both. December means in January, PGs have class. So, even PGs and UGs both can attend in December first week or so. We'll plan it, and definitely we'll have it. At least surgery and medicine this year, definitely we'll have. Okay, and most of them sir has already covered in the GP, and excellent class, excellent class. I have no words to say. Anyone any doubts you can ask, or else if in YouTube also there are so many doubts, sir. If you could see that and answer on kleptocracy, all these are foreign members we are having. Godfather has best, like Godfather has told you, sir, awesomely explaining. He loves you a lot. Okay, if your wife sees that, gone. And kleptocracy rules as mentioned. What's the difference between dehydration and hypovolemia, sir?
Okay.
And can you tell which are external malignancy markers? So many doubts are there.
Okay.
If
Yeah, dehydration versus hypovolemia. I mean, one of the hypovolemia is caused. One of the causes of,
intravascular loss.
yeah. No,
Dehydration is cellular loss, whereas hypovolemia is intravascular volume loss. As simple as that. Okay.
absolutely, sir. And external markers of malignancy. So, for example, acanthosis, especially GI adenocarcinomas, stomach adenocarcinoma, they can have acanthosis nigricans as one of the markers. So, there's something called sign of lesser patrilat. That can have keratotic lesions in the palms, and then
Migratory superficial thrombophlebitis, marker of CA pancreas.
absolutely. Even CA lung, CA pancreas, CA lung, both can have that. It's called
Yeah.
Trogger's syndrome. Trogger's sign, I'm sorry.
Traugios.
Trogger's,
Traugios sign. Yeah.
Trogger's sign. And
Traugios, and you have this what is the Sister Mary Joseph nodule,
Mary Joseph nodule,
or any
and clubbing
in
also.
umbilicus, and
Yeah, clubbing is actually
yes, yes.
CA lung. Clubbing is also an external marker of malignancy.
Correct.
Um,
Finally, your eyes will see what your mind knows. Okay, so your theory knowledge should be sound. Only then you can appreciate it on the patients. If you don't have a thorough theory knowledge, then whatever big signs are there, whatever is there, you can't appreciate unless you know them. What is Trauger's sign? What is Trauger's sign? Or whatever sister may, whatever we mentioned, you should know at least what they refer to. Only then you can pick them up and make a big diagnosis. To become a good clinician, or to become to improve your clinical acumen, you need to be very observant and practice. Like service, there is no alternative but for practice in our field. Okay, even now I am learning how to do a proper abdomen examination, even after so many years, because doing abdomen examination is such a tedious thing. 4-5 things at a time you're doing. So okay, it's not just palpating the abdomen. You need to be looking continuously at his facial expression. You need to be looking at his respiratory pattern. You need to be continuously distracting him to avoid the guarding and all. And continuously you have to be moving all around the regions. So it's very, very difficult. Doing one thing only difficult. So just imagine doing 5 things at a time. That to suddenly going on exam day and doing it would be much more difficult. So practice it. I would say only 3 things which can make you a perfect clinician. One is practice, second is practice, and third one is it's practice only. Okay, so nothing else. So,
Me too.
sir, any concluding remarks from your side?
No, I think hopefully it was a fruitful session. Maybe it went a little longer. Maybe we'll have to be careful over the timing. Otherwise, I was glad that it was interactive and students were.
Thing is that thing is that why it went long was not because of your class, sir. Your content was only for 45 minutes or so, but they asked so many doubts, and you clarified them so well that that's why it went on for 2 hours. I think students would agree with me. What about Venkat? Am I right? Or Yash? Half of the session taken by Venkat himself, not you, sir. And Venkat,
Very smart.
today's session was half Akshay, sir, half Venkat's today. Okay. Anyway, it was too good, sir. Too good. Students need that kind of, because this is not for any one particular subject or one particular year. This particular, I was still telling the same here, sitting at my home also. This one particular topic is useful for each and every medical student and each and every doctor for that matter. See, even now I'm learning something out of this, means that shows the importance of this particular topic. So it's never a waste. Spending 2 hours or 3 hours for this topic would be very much like appropriate and worth it. I was telling, if Akshay sir somehow finished this in 2 hours. If I had taken this class, I would have taken for entire day. So it's worth it, sir. Worth it.
Very true. Very true.
Venkat, anything from your side you want to add? You can unmute yourself and tell.
He's already asked. I think he wants more sessions. Better to launch practical course.
Okay, we will do that. Okay. We'll definitely do that. Okay. Many have been requesting the same. So sir is a very busy clinician, so his practice goes beyond the timings. So finding him and getting him for the class is only very difficult thing for us. Anyway, he's very considerate and kind enough to do classes for us regularly, and he's taken so many classes for us, which students are finding very, very useful. Hopefully definitely before your exams, definitely we'll conduct one practical class, because the main intention of these Vitamin classes are the same. Theory, you have so many sources to read books and videos, but for practical, not many, and that has to be learned from a proper mentor only. It can't be learned by just mere studying from books. You need a good mentor like this to explain you, teach you. Unfortunately, most of the medical student doesn't teach you properly in the clinics. But here in White Army, you get to learn each and everything from the best of the best teachers who are very passionate and dedicated. So we'll definitely consider all your requests, and we'll try to fulfill. Thank you so much. Shall we wind it off, sir?
Sure, sir. Thank you, everyone.
Yeah. Thank you so much. Thank you. Yeah.